Okay, good morning, everybody. I'm going to call the meeting to order. As the vice chair, I'm filling in today for Secretary Johnson, who will be participating later today remotely due to an illness, and will handle that when she arrives. This meeting is being recorded, and now I'd like to ask for a roll call, please.
Dr. Sandra Hernandez.
Here.
Richard Cronick. Ian Lewis.
Present.
Elizabeth Mitchell.
Here.
Richard Pan.
Present.
Don Moulds. Secretary Kim Johnson. That completes roll call.
Great. With that, I believe we have established quorum. I'll now hand it over to Director Landsberg for her report.
Thank you very much, Madam Chair. Good morning, everyone. On today's agenda is a continued discussion of data submission enforcement, including feedback from the Healthcare Affordability Advisory Committee. This topic will be taken out of order prior to a potential vote to approve the data submission enforcement penalty scope and range. And if the board does not vote today, the item will be placed on November's agenda. Also on the agenda is a continued discussion of spending target enforcement, specifically waiver of enforcement, technical assistance, and public testimony. I will now move to executive updates. Last Monday, we celebrated Indigenous Peoples Day. California is home to the largest number of federally recognized tribal nations, 109, as well as, and if we can go to the next slide, please, as well as 62 non-federally recognized tribes indigenous to the state. So as we do every year at this time, I'd like to start today's meeting with HCI's land acknowledgement statement developed by HCI's racial equity team. I won't read aloud the whole land acknowledgement, though I do want to note that HCI's LA and Sacramento offices sit on land stolen from the Miwok, Nishinan, Chumash, and Gabrielino Tongva people. We think it's important to have this land acknowledgement statement as a reminder of the historical truths about government-sanctioned violence and mistreatment of Native peoples, their resilience and fortitude in the face of such treatment, and HCI's endeavor to promote racial and health equity throughout our workforce and within many public programs by revisiting policies and procedures to align state resources equitably in a manner that recognizes our responsibility to address disparities. More important than doing the land acknowledgement is to talk about the work that we're actually doing. And so I'll be talking in a few minutes about HCI's work to put together California's application for the Rural Health Transformation Program. And in the course of that, we've had important meetings with tribal communities, including our first ever formal tribal consultation, which we did a week and a half ago. So really important as we think about the healthcare needs of rural communities that we specifically engage with tribal communities. So it was very helpful to hear from a number of chair people of California tribes about the needs that their communities are facing, about the long distances they sometimes travel, particular focus on wanting to make sure they have access to primary care, maternity care, mental health, and substance use disorder services, and to use some of their traditional healing methods intertwined in responding to some of those needs. So it was a privilege to take part in that. All right. Moving on to additional executive updates, I will note that the California Hospital Association filed suit against HCI, the Office of Healthcare Affordability, and the Healthcare Affordability Board in San Francisco Superior Court last week on October 15th. The lawsuit challenges the actions of the department, the office, and this board, and myself as director, related to the statewide spending target, as well as the hospital sector, including the definition of the hospital sector, the method used to identify high-cost hospitals, and the target for the high-cost hospitals. HCI does not comment on pending litigation. The Office of Healthcare Affordability was created by Governor Newsom to drive toward a lower-cost, high-value healthcare system. The spending targets are a critical tool to address affordability, paired with approaches to promote system performance, including investing in primary and preventive care and adopting payment models that reward quality, all of which have been shown to improve health outcomes and lower overall health spending. The Office of Healthcare Affordability will continue our important work to help reduce the cost of healthcare in California. Next, you may have heard the exciting news that last week, or was it? Yes, I believe it was last week, that through HCI's CalRx biosimilar insulin initiative, California has become the first state to offer its own low-cost insulin starting on January 1st, 2026. The state-backed program will provide insulin glargine pens. Glargine is a long-acting insulin used for diabetes management at a maximum price of $55 for a 5-pack, and pharmacies can purchase these pens for $45. I want to recognize then Senator Pan's leadership in starting the CalRx program. He and Vishal were at the governor's first press conference in Kaiser a number of years ago. When we kicked off the initiative, we were last week at Cedars-Sinai in the specialty pharmacy. I think it was actually the week before. Regardless, it was a really exciting announcement. So, this initiative really underscores California's commitment to improving medication affordability and accessibility, especially for uninsured, but also very importantly for underinsured residents who typically must pay the list price for insulin and spend thousands of dollars a year to obtain these life-sustaining and life-saving medications. By eliminating reliance on coupons, discounts, and rebates, except federally mandated rebates, CalRx promotes pricing transparency benefiting all consumers. The CalRx biosimilar insulin initiative is part of our broader strategy. And I think it really is exciting that we said the pharmaceutical industry is never going to police itself. It's never going to change things. We have to fundamentally interrupt the very profit-motivated pharmaceutical industry. So we're excited. Today, the price for this insulin is between $88 and more than $400 for a 5-pack, and we're going to be bringing it to market at $55 for a 5-pack. So really proud of Vishal and our CalRx team for the work to get us to this point. So this is a white label partnership as our Civica CalRx partner continues to work to develop our own manufactured insulin product. So that was a good day. Okay, moving on to legislation. Governor Newsom had until October 13th to decide whether to sign or veto bills, and so he did sign a number of bills into law that impact HCI that we wanted to bring to the board's attention. Assembly Bill 1415 was signed into law. This broadens the scope of our OCA oversight, so it expands the OCA's authority to require MSOs, private equity groups, hedge funds, as well as newly created entities that own operator control providers to file that notice with us if there's a proposed merger or acquisition. So you all know that if there's a proposed merger or acquisition involving a healthcare entity, the healthcare entity has to file the notice with us, and this will require the private equity hedge fund or MSO also to file with us. And we believe these amendments will enable OCA to better monitor transactions by ensuring all parties to the transaction file information with OCA. OCA's oversight of MSOs will not be limited to transaction reviews. AB 1415 also authorizes OCA to collect data and information about MSOs, management services organizations, like other healthcare entities subject to OCA's current data submission requirements. So we think this is a positive move for increased public transparency. The governor also signed Senate Bill 660 related to the data exchange framework. So SB 660 makes official that the data exchange framework is moving to HCI. It also expands the entities and clarifies the entities required to participate in the data exchange framework and required signatories and data exchangers. Revises the stakeholder governance process, both in terms of the membership and the scope, and then requires HCI, along with the advisory committee, to develop a report to the legislature involving a number of things, including enforcement approaches and governance. AB 1312 is a follow-up bill to the hospital fair billing program. It requires hospitals to, it basically brings a presumptive eligibility approach to hospital discount policies and charity care. And I'll talk in a minute about LA County's approach to addressing medical debt. So under AB 1312, hospitals will have to check if patients qualify for programs such as CalFresh and CalWorks, and if they do, they have to assume that patients qualify for financial assistance. Other legislation impacting affordability are Senate Bill 40 and Senate Bill 41 related to prescription drug affordability. So SB 40 will prohibit health plans and insurers from imposing cost sharing of more than $35 for a 30-day supply of insulin. So we think these are important parallel efforts to try to bring down the cost of insulin. The bill also bans step therapy for insulin coverage and requires plans to include at least one insulin for each drug type on their formulary. And then Senate Bill 41 is attempting to have additional constraints on PBMs, pharmacy benefit managers, following on the budget action that will require PBMs to be licensed by the Department of Managed Healthcare and to submit data to our HPD. Senate Bill 41 also prohibits spread pricing by PBMs and requires PBMs and group purchasing organizations to pass through 100% of manufacturer rebates to health plans, prohibits PBMs from marking up the price of generic drugs, and bans PBMs from steering patients to their own pharmacies. So we think this is a great combination. Obviously, the governor signed many other healthcare related bills, but these are the ones most clearly focused on affordability. I also wanted to mention AB 144, which is a budget health trailer bill, budget junior, passed in August, which establishes the Abortion Access Fund to support abortion access and services. So the bill authorizes HCI to distribute funds to ensure Planned Parenthood continues to receive funds to provide services in California, as they are not eligible for federal funds because of actions taken under H.R. 1, the federal reconciliation bill. So they're prohibited from receiving Medicaid funding for a year as a quote-unquote prohibited entity, and so the administration's taking a number of actions to try to support Planned Parenthood. So that is some on legislation. I don't have a slide for this, but I did want to just spend a minute talking about a medical debt summit that I attended in Los Angeles last week. And to share some of my takeaways. So Los Angeles has done a pretty remarkable thing. They have identified medical debt as a public health problem, and really, which I think is innovative and really important. So they had I think their third medical debt summit last year. One of the things that was noteworthy, in addition to that frame of medical debt as a public health crisis, is the wonderful coalition that they have built. So they have at the table, they have consumer advocates. So there were folks from Health Access and Western Center and CPEN who were there, also representatives of the Southern California Hospital Association, along with clinic representatives and health plan representatives and folks from the public health department, really working together to figure out, it's not good for anyone to have this level of medical debt. People don't come back to get the healthcare services they need, and how can we work together? And so really appreciated that collaboration and willingness to sometimes have some hard conversations, but willing to try to challenge one another and work together to try to reach a common goal. I was also very struck by one of the advocates who talked about the violence that is part of medical debt collection. And he said, we shouldn't just think that this is just people getting a bill. He said, I have clients who there's someone waiting outside their house. There's someone calling them every day. They're scared. And particularly in the context of the immigration raids and use of force against people, that this is really very disruptive. And so that was very noteworthy to me to realize what the additional stress that having medical debt can face. So I was pleased to be a speaker talking about our efforts to try to improve affordability, our efforts to try to make sure that hospitals are complying with the hospital fair billing program, as well as talking about our oversight of market consolidation, that really is a medical debt issue also, because when we have the market power and we have providers that aren't part of networks, that contributes to people acquiring medical debt. So was pleased to be part of that. All right. Next is an update on California's Rural Health Transformation Program application. So the Rural Health Transformation Program is the 5-year, $50 billion initiative established under H.R. 1 for states to strengthen healthcare in rural communities. So it has been made very clear in the statute, in our conversations with CMS, that this can't be supplanting or making up for the Medicaid cuts, which are going to be very disturbing, very detrimental to providers and consumers as they lose coverage, but really trying to change the way healthcare is provided. So we did a survey. We heard from 368 stakeholders in California. We've had a very short period of time to put together our application, which is due a week from tomorrow, but we're going to try to get it in a day or two early in case systems crash or the like. So after hearing from a lot of stakeholders and pulling together our experience at HCI, we are moving forward with these 3 basic initiatives. So we have our transformative care model, and really undergirding that, and very necessary, as we heard from all the stakeholders, is additional investment in technology and tools and in workforce development. So our transformative care model, this is happening somewhat informally, where there is a larger hospital that serves as a hub, and then spokes are rural hospitals, clinics, tribal clinics, physician practices, community-based organizations like CHWs. We're never going to have every specialist in small rural communities, but if we have more of these formalized hub and spokes models, where the spokes are focusing on primary care and maternity care, we have increased remote patient monitoring and e-consults, where the spokes can get support from the hub hospital for specialty care. We think we can make a real difference in access, avoiding rural bypass where folks drive long distances to get specialty care. And we can try to really shore up and increase the financial stability of those rural networks. So it's been great to learn from existing folks who are doing this today, and with those groups we'll have accelerator partnerships, and then seek to build out some new hub and spokes models and bring some dollars to the table. We're also looking at possibilities for payment reform. We don't have time nor funding available to really do a full global payment system, but we are looking at some type of trying to provide some kind of stability payment to rural hospitals who have to operate 24/7 alongside fee-for-service payments to try to bring them better financial stability. On the technology and tools, which is something that the federal government has really emphasized, wanting to make sure, and we've heard from a lot of rural providers that they need help modernizing their electronic health records, really meaningfully engaging in data exchange. Having better systems to guard against cybersecurity attacks. So we're looking at creating a technical assistance center and some shared purchasing of some of those services. I think it's difficult for every rural CEO and CFO to have to purchase these services on their own, so seeing if we can come together and provide them with technical assistance and some shared resources and funding to modernize their systems and have the technology and tools they need to provide care. And then uniformly, we heard about the need to develop the workforce in rural areas, and the need to really develop a locally rooted workforce, so to have grow your own approaches where we're doing more outreach and pipeline efforts to bring folks in from those rural communities, give them the skills to become healthcare professionals in their own communities. I was very pleased in the NOFO, in the Notice of Federal Opportunity, to read a lot about community health workers and patient navigators and a recognition by the federal government about the importance of those workforces. So I think we'll be focusing on primary care, maternity care, allied health professionals, midwives, doulas, some of these technician positions, focusing on retention and recruitment, and then providing behavioral health training to primary care and maternity care providers to better enable them to provide whole person integrated care alongside all the many efforts that California is engaged in to actually train more behavioral health professionals. So it's been a heavy lift. We're getting close to submitting, like I said, in just over a week, and really appreciate all the stakeholder engagement and support we've gotten from so many in the community. And I think that is plenty from me. With that, I'm pleased to turn it over to Deputy Director Vishal Pagani.
Thank you, Director.
Unless anyone has questions for me now. I was going to skip the HPD updates for next time. Yes, Dr. Pan.
No, thank you for that presentation, and obviously a lot of things going on, and thank you for, I appreciate the work that HCI has done and the Newsom administration on implementing CalRx, so it's very exciting to see that announcement. I would make note that as we were deciding how we're going to try to improve affordability for pharmaceuticals, and appreciate that the governor signed a bill to cap the copay, that what we heard about just capping copays is that what that does is that if you don't actually bring the price of the pharmaceutical down, it just pushes the cost out to everyone else and raises healthcare premiums for people. So this was really an effort to try to be sure we get at the heart of this. The other thing I would make note is I believe there was a USC study that showed that the increase in insulin costs actually more recently were driven by the middlemen, the PBMs and so forth. So I know that when we did the bill, some of the conversations were also not just about, the price, but also how we distribute it in a way that basically cuts out a lot of the middleman problem that also drives up the costs as well. So that you talked about the transparency, and I think that's a very important element. So it's not simply saying that we're going to provide insulin, but also we don't engage in the gamesmanship that unfortunately hides the actual cost and also hides the profit that many entities make, even from the point of manufacturer to finally getting to the hands of the patient. So again, appreciate that work. I also make note that unfortunately, I think this is fairly recent news that the Trump administration, I think, is planning to try to preempt any sort of effort on the medical debt to actually allow state efforts to take medical debt off of people's credit reports. So hopefully the people will stand up and say, in addition to the fact that they're planning to pretty much double people's premiums who are in the exchange or Covered California here and cut Medicaid, that we're also going to add medical debt to your credit reports as well. And so just going in the total wrong direction, I think, in healthcare and making it much less affordable. And I'm glad to know that California continues to take leadership trying to push back as well, not just push back, but actually take leadership. I mean, the CalRx was not an effort to push back on the Trump administration. It was an innovative effort by California to say, we need to be innovative and forward-thinking and trying to be sure healthcare is more affordable for patients. So I appreciate the work HCI is doing on that. Thank you.
Thank you, and I did see the regulatory change that may impact, because California did pass legislation saying that medical debt cannot be reported to credit reporters, so we'll have to evaluate that. And in terms of the Medicaid and other cuts in HR 1, I should note the California Health and Human Services Agency has sponsored a series of webinars. There was one yesterday talking about the impacts of HR 1. So if folks didn't see that yesterday, it's on CalHHS's website and our website. Michelle Boss talking about the cuts to Medicaid and the work that DHCS is unfortunately starting to do on work requirements and some of the other changes. And then it's really devastating that starting on Saturday, 5.5 million Californians won't have the federal food assistance under the SNAP program. And so the administration's filing suit against the Trump administration about that.
Ian?
Yeah, just a quick follow-up on that, I think, in the rural health funds. Do we know of anything at this point within HR1 or CMS regs that are attaching contingencies on that funding that could compromise equitable care, especially I'm thinking around sexuality or gender-based care?
Yeah, thanks, Ian. There is a I need to look more at the fine print, but there are some requirements around following some of the executive orders. It's California's contention that we are certainly not discriminating against or granting preferential treatment on the basis of sex, race, ethnicity, and that there's some questionable interpretations that are being engaged with. So,
Elizabeth?
Thank you for these terrific updates. Just a point on the Rural Health Transformation Fund. California Quality Collaborative has done extensive work consulting with practices on sort of transformation, and with technical assistance, they have terrific evidence that it reduces hospitalizations, ED visits, and it expands the staffing model to include community health workers and addressing social needs and behavioral health. So there's a lot of evidence around California about what does work that we're happy to contribute or share if it's helpful. But then my question was, are you are you seeing receptivity to this work? Because in some cases when, technical assistance has been offered, it has been not particularly welcome with health systems and hospitals. So just wondering if there's what is the buy-in to this?
yeah, I think we've had a lot of receptivity and collaboration in terms of entities coming forward with ideas. I think we're just starting to spell out what our 3 initiatives are, but I'm very optimistic that we'll have good uptake, and it'll be really important. I mean, with each of these components, we're going to start with an assessment piece to really understand and hear directly from rural hospitals, from rural clinics, what do they need, to try to structure it in a way that'll be most helpful to them. And yes, we'll take you up on the offer of information.
We're going to turn it over to Vishal to do a little more updates. Vishal?
Thank you, Chair Hernandez. First, I'd like to inform the board and the public that Eliza Arjuan recently announced her resignation from the Healthcare Affordability Advisory Committee. She was appointed to represent payers. We will soon reopen the advisory committee submission of interest process and return to the board in November to establish a subcommittee to review the submissions and make a recommendation to fill the vacancy. The next advisory committee meeting is in January. Next, I'd like to highlight 3 recently published articles, starting with the California Healthcare Foundation's piece titled "The 25% Problem: Why Healthcare is So Expensive and What We Can Do About It." The article posits that healthcare is too expensive for people, largely due to underlying costs in the healthcare system that have grown unchecked for decades. The solution isn't to cut spending across the board, but to be smart and focus on the 25% of spending that doesn't provide value for patients. The top 3 categories of this spending, which adds up to an estimated $73 billion a year in California, include red tape, paperwork, and other administrative waste, excessive profits for companies that can charge unfair prices because they have no or not enough competition, and treating serious illnesses that could have been caught early or prevented altogether with basic primary care. The paper goes on to take a deeper dive into these 3 areas. For example, administrative waste happens because our healthcare system is so complex. Different hospitals, doctors, and insurance companies often use different computer systems for clinical data, billing, and administrative tasks, and can't easily share information with each other. This means staff in different parts of the system spend extra time entering the same information over and over. Insurance companies and hospitals have to hire more people just to handle paperwork, and simple tasks become complicated and expensive. At nearly $20 billion a year, administrative waste is the top source of spending that the article describes as doing nothing to help patients or improve care. The second cause of spending noted in the article is unfair pricing with too few choices. In California, the same procedure can cost wildly different amounts depending on where you go, without a difference in quality. In many areas, competition is lacking for both hospitals and insurance companies. When these entities don't have to compete, prices can go up without any improvement in care quality. Patients have fewer choices about where to get care. Families pay more for the same treatment. And some areas become take it or leave it markets. This creates unfair contracts where the biggest companies can demand high prices because patients have nowhere else to go. The article's third area of focus is not enough prevention in healthcare, leading to more serious and costly disease complications and expensive hospital stays. Too often people don't get early checkups because a primary care doctor is not available when they need it. California spends as little as only 7 cents of every healthcare dollar on primary care. However, research shows that we could save billions by helping people stay healthy instead of waiting until they get really sick. The article then offers solutions and highlights the work of OCA, including spending targets to incent healthcare entities to manage their underlying costs and reviewing healthcare mergers and acquisitions. Additional solutions noted in the research as being pursued by policymakers, industry leaders, and advocates include reducing prior authorization, implementing a statewide data exchange, addressing monopolistic pricing, and increasing investments in primary care. Next slide. The next two articles I'm going to speak to were published in the Health Affairs Forefront. The first one is from Baylor Health, in which 2023 spending data from 5 states with healthcare costs growth targets showed about a 40% increase in non-claims payments, driven largely by increases in Medicare Advantage non-claim spending. While increases in non-claims payments are often seen as a positive sign, suggesting a shift away from fee-for-service payments towards alternative payment models, or APMs, a closer examination revealed insurer-provider vertical integration potentially weakening the effectiveness of the medical loss ratio requirements for insurers. As a reminder, the MLR established in the ACA generally requires either 80% or 85% of an insurer's premiums to go towards medical care and quality improvement activities, as opposed to administration, marketing, or profit. In addition, a company is vertically integrated when it owns or controls more than one entity in the supply chain. For insurers, this means acquiring physician practices, clinics, and sometimes entire health systems. As a result of this vertical integration, payments to affiliated providers count as medical spending when calculating the insurer's medical loss ratio. However, because there's no MLR requirement for providers, it creates an incentive for the insurer to direct spending to these affiliated provider entities who may charge inflated prices, and allows the insurer to increase its reported MLR without delivering more care or improving quality. Shown here on this slide, the authors present a scenario in which Company X owns health insurer A and Clinic Y. Another health insurer B, who is not owned by Company X, or which is not owned by Company X. When a patient covered by health insurer B receives a service at Clinic B, insurer B pays the clinic $300. But when another patient covered instead by health insurer A receives the same service at Clinic Y, health insurer A pays the clinic a lot more, $500. The full $500 is counted as medical spending in health insurer A's medical loss ratio calculation, even though the additional $200 didn't buy any more services or any better care. It just represents internal profit for the vertically integrated entity, Company X, that is captured on the provider side of the business and not true care delivery. The authors go on to note that this dynamic reveals a limitation of MLR rules. When the insurer is also the provider, there's less transparency into how healthcare dollars are actually allocated, and the vertically integrated insurer and provider entity can also artificially inflate prices for medical services. Currently, there's not a standard way to assess the extent to which insurers that own or are otherwise affiliated with clinics and health systems are taking advantage of this loophole, according to the authors, or how much the practice contributes to high healthcare prices. However, the growing trend toward insurer-provider vertical integration, the potential cost implications are significant. With little attention being given to this MLR loophole and the ability of vertically integrated insurers to report profits as medical care, the authors recommend that states require insurers to report detailed information on transactions between related parties, including non-claims-based APMs to affiliated providers, and the pricing methodology used to develop these alternative payments. The reporting could be integrated into a state's premium rate review process, allowing regulators to assess whether such transactions reflect medical costs. The authors also note that the state could then modify or deny rate increases where evidence points to potential gaming of the MLR rules. And then lastly, the authors recommend that policymakers reassess whether regulatory tools such as the MLR are adequate. Addressing these issues will be essential for maintaining the integrity of cost containment efforts and ensuring healthcare dollars are spent on delivering meaningful care. And then I'll take us to our next article, which is looks at various approaches states have taken to address high and rising hospital prices, including implementing hospital price caps, both to limit price increases resulting from consolidation and to discourage future consolidation. Some states have enacted hospital price caps solely in their state employee health plans, while others have established caps across the entire market. One example is from 2017 in Oregon. They capped the amount its state employee health plan would pay hospitals at 200% of Medicare for in-network services and 185% for out-of-network services. This policy has saved Oregon around $50 million annually and has resulted in an estimated 9.5% reduction in hospital out-of-pocket spending for state employees. To date, all 24 hospitals that were in the plan's network prior to the policy have remained in network, which the authors suggest is due to the way they structure their program by having a lower cap on out-of-network providers. This year, Washington State joined Oregon to adopt an across-the-board cap on hospital payments at 200% of Medicare, the same amounts as Oregon under its state employee health plan, with any savings passed on to employees via lower premiums. The Washington law also established payment floors for primary care and behavioral health services, meaning that their payments should be no less than 150% of Medicare. They exempt critical access and other select hospitals from the cap, while also setting a reimbursement floor of 101% of Medicare for services provided at these critical access hospitals. So in addition to Washington, Colorado, Nevada, and New Jersey, or in addition to Washington, other states like Colorado, Nevada, and New Jersey also have bills filed this session to establish reference-based hospital price caps in their state employee health plans. So just going on to Vermont and Indiana, which in 2025 became the first two states to enact legislation capping the prices that hospitals can charge across all commercial payers. Vermont's new law directs an independent board to establish upper limits on the amounts hospitals can accept as payment for healthcare services based on a percentage of Medicare rates, while also setting price floors for certain services in non-hospital settings such as primary care. The law also requires savings to be passed along to ratepayers through lower premiums. The price caps in Vermont also serve as stepping stones towards establishing global hospital budgets, which they're required to do by fiscal year 2030. The new law in Indiana differs from Vermont in that it requires non-profit hospitals to bring their aggregate average inpatient and outpatient prices under statewide averages by June 2029. If a non-profit hospital fails to meet this requirement, the hospital is subject to forfeiting its nonprofit status until it can lower prices below statewide averages. In addition to Vermont and Indiana, bills to establish reference-based hospital price caps that would apply to all patients were filed in Massachusetts, Montana, and Oklahoma. These bills were drafted by both Democrats and Republicans, demonstrating bipartisan support. And then lastly, the authors conclude that because of the inherent impact of price controls on hospital revenue in the commercial market, policy should be implemented in a way that closely monitors hospitals' financial health. They note that Vermont's law directs the board to identify factors that would necessitate terminating or modifying price caps in hospitals, including reductions in care access or quality, while Indiana's law includes a provision requiring nonprofit health systems to submit audited financial statements annually to the state, ensuring that it can monitor the impacts of the price caps. And then I just have one more update, which is about our 2025 data collection progress. So shown here are 47 of OCA's 50 submitters have submitted all files and passed validations. As of this morning, this data is already out of date. We have 48 submitters now that have filed or passed validations, and then we anticipate the remaining 2 submitters will submit their files by tomorrow. And we're continuing to follow up on manual validations with some plans, and are working through those on a case-by-case basis. And then taking us to our last slide. So as we do at every meeting, just as a reminder for the board and the public, yellow areas are informational items where we're seeking your input, the public's input. And these are areas for OCA's decision making, and the green areas indicate areas for the board's decision making. And I'll turn it back over to the chair.
Thank you, Vishal. Appreciate that. Any comments from the board? Elizabeth, please.
Thank you, and thank you for the presentation. I wanted to share that PBGH, our organization, just completed an analysis of pricing using the newly available price transparency data with claims and quality and safety. And included in that were both Northern and Southern California. So you can identify hospital pricing named by the facility. We're happy to share that. It's in the public domain. The variation, of course, is wild and has absolutely no correlation to quality. So as you are tracking the hospital cost growth, this is, I think, another tool to use, because the pricing data is somewhat different than the claims data, but it's complementary. So we're happy to submit that. And the other point I would make is typically what happens is if there is any downward pressure on costs from the state employee health plan or others, it's just shifted to the private employers. So it's worth having a multi-purchaser strategy. Like, we have some members who are doing similar price caps, saying they won't pay a claim over whatever 250% of Medicare unless there is data that truly justifies that. And that is, it's happening in various places. It is not at scale, but I think it's just worth thinking about how do we align with the private purchasers as well as the state, because to avoid the cost shifting.
Thanks, Elizabeth. At least some of the literature I've read in this area, the state employee, they do tend to focus on the state regulated plans. There are some proposals where instead of focusing specifically on those markets, you could cap the amount that hospitals can charge. So that's kind of a way to, regarding ERISA and kind of the federal government's role, that you could kind of approach it from the angle of what hospitals can charge versus kind of what the negotiated payment is between self-insured employers and hospitals, which is kind of the domain of the federal government.
Other questions or comments from the board? Ian?
Yeah, on that same point, it's remarkable to me that Indiana is out there as a leader, and I know there are some unique dynamics, but at the core of that, I think, is a very, very active employer side purchaser coalition, and it really speaks, as you said, Michelle, to the nonpartisan sense of pressure that this country is feeling on hospital prices. I also wanted to say, with regard to the CHCF report, I think this framework is really helpful. I would speculate that both the scale and the distribution of the money that is not going to fund care is very different by market segment: Medi-Cal, Medicare, and commercial. And within commercial, it's probably very different, very sensitive to cost sharing. And it struck me that this would shining more light on that, both keeping that framework up to date over as time goes on, and teasing out how it's different, especially in the commercial market, might be something we build into our annual reporting at OCA.
Dr. Pan?
Well, thank you, and thank you, Michelle, for the presentation. I appreciate it. Making note that administrative waste is 28.4% in the CHCF report. That sort of corresponds to the percent amount of time primary care doctors actually spend with patients. I brought this up before. If we only allowed primary care doctors to spend 50% of their time with patients, we could almost double our primary care workforce without training a single new primary care physician. That actually also speaks to perhaps the follow-up report on medical loss ratio goals. Now, certainly that paper focused on manipulation where, for example, by being an integrated entity, you could shift the profit to the provider and have it count. But I also make note that, and we've talked about this before, is that even in non-integrated entities, what we've seen is that you have plans essentially pushing administrative costs onto practices. Prior authorization is an example where that burden is more borne by the practice than by the plan. Therefore, but those costs, and we talked about like, hey, what's the administrative cost at the practice level? Because those costs are actually considered clinical. They're not considered administrative. So when you push those administrative costs from the plan to the providers, then you actually improve your medical cost ratio, but actually you're not delivering any additional care. And that goes back to, again, how much time are we allowing the providers actually to provide care? Because that's a workforce problem. We talk about shortages. Well, part of the shortage is because we're not allowing clinicians to actually provide clinical care. Instead, we're making them do a lot of paperwork. They're probably the most highly paid data entry people, in the country. But that's not a very good use of their time. And so I think as we are looking at, if we're looking at, and I appreciate the new laws also in place, as we're looking at exactly, where the money's going, I think we do need to look at to what degree are things being shifted down to providers, costs being shifted to providers that actually aren't value added in terms of care. It's just more, administrative work that plans or others, risk-bearing organizations may want to displace because they perceive that that's going to, that actually there is an incentive there. Not just that doesn't just reduce costs; it actually allows them with MLR to actually get an increased shift the profit to their side, right? So I think that that's something we need to pay close attention to. But ultimately, even as we're thinking about an HCI as a workforce organization, we're not, but the rest of HCI does a lot of workforce stuff, is we need to think about not only the number of people, but how they spend their time. And how do we ensure that they spend their time taking care of patients and not spending most of their time doing the overhead?
Let me really thank the board for those comments. I'll open it up to the public in a moment. I just wanted to add that it seems to me, in the spirit of the board keeping an eye on consumers, that a lot of this administrative complexity is complexity that's borne by consumers as they try to figure out how data and information moves from one place to another. And so the work that's been done on data exchange, I continue to believe, is an urgency that is technically easy to do if everybody would lean into it. And consumers continue to bear a lot of the burden of this administrative complexity that does not only not serve their care needs well, but also we put a lot of that burden on them to manage a system that is overly complex and doesn't really serve their needs. Dr. Pan.
No, I appreciate that, but I also, as someone who's been on the front lines, know that you have a lot of physicians and their staff trying to help patients with that. Yes, the complexity makes it really hard for the patients, and then you have people trying to help them, and they're spending a lot of time doing that too. So I fully agree.
We have a lot of our workforce trying to help them deal with that are not actually working on healthcare issues. Yeah,
exactly.
I agree, Dr. Pan. Okay. With that, let me open it up for any public comment on what was a very robust executive director report and Vishal's review of really important literature.
Thank you. First, I just want to acknowledge that board member Richard Cronick has joined us and did so just a few minutes after roll call, so welcome. We'll now recognize members of the public for comment on the executive welcome. Please reserve comments on other items for the general public comment period. To ensure equitable access to verbal public comment, we will alternate between members of the public present in this room and those attending virtually. Those in this room may line up at the podium. Those attending virtually who want to connect and comment should click on the raise hand button. Those dialing in can press *5 to raise your hand. It will track the order in which the hands were raised. During the public comment period, you will be unmuted when it is your turn. We also invite you to provide written comment at oca@hchi.ca.gov. Please keep your comments to 2 minutes or less so we can hear from as many members of the public as possible. Please note that while the Healthcare Affordability Board is committed to communication and transparency, board members and staff will not be responding to public comment. Additionally, the board may not discuss or act on any matter raised during the public comment period that is not included in the meeting agenda, except to place the matter on a future agenda. I'll start with individuals at the podium. Please go ahead.
Beth Capel for Health Access California. It's always such a rich discussion when the board engages with the updates. Let me begin by saying that Health Access was both at the CalRx announcement and the LA County Department of Public Health meeting. And we were very pleased to hear the governor say that he was committed to crushing healthcare costs. CalRx is clearly part of that, so is the work you're doing today. And we are also pleased to see so many bills that we worked on and contributed to signed in this round. With respect to the focus on consumer affordability and the impact on consumers, there is an enormous amount of overhead in this system that does not facilitate care or help consumers in any way. We checked the footnotes on that 25% piece and saw a piece by J.G. Kahn and I think R. Cronick that dated back a few years on how much overhead there is because of the multiplicity of payers. Simply simplifying billing codes would save a whole lot of money. I also want to pick up on something that board member Inlow said about the impact of this waste on consumers. To the extent that cost sharing deters people from prevention, and I think we all know it does, that is part of what's contributing to unnecessary spending. And it's something that is constantly in our mind as we look at cost sharing, whether here or at Covered California. We also want, for those of us who remember the prior version of this department, OSHPD, I would simply note how much more HCI is doing and how exciting all this work is, and to appreciate that work. So thank you. We appreciate the opportunity.
Thank you. Now we'll turn to look to see if there's members online who wish to speak. Sean Kim, we're unmuting you on our end. Please unmute and go ahead.
Good morning, board. My name is Sean Kim, representing California Pharmacists Association, the sponsor of SB 41 PBM reform. SB 41 builds the last year's SB 966 to advance fairness, transparency, and accountability across the pharmaceutical supply chain. The law prohibits the spread pricing, requires PBMs and GPOs to pass through the manufacturer rebates to payers, and bans the PBMs for marking up the generic drugs and prevent PBMs to steering patients to PBM-owned pharmacies. Vertical integration is real and very apparent, driving the total cost of healthcare passing down to every entities but PBMs. These reforms are not limited to community-based pharmacy. They are touching entirety of the healthcare system, inpatient, outpatient hospitals, long-term care, infusion center, integrated care, physician officer, and more. Wherever the medications are prescribed, administered, or managed, PBM practice shapes the access and affordability. CPHA respectfully requests the pharmacy to be formally included as SB 41 implementation discussion, especially deciding on what data should be captured to bring the transparency. We not only sponsored the bill, we worked on the educate the public, policymakers, patients, and consumers about PBM practices and their real-world impact on access, affordability, and continuity of care. Our thousands of pharmacists and pharmacy technicians see these issues daily and can provide pragmatic frontline insight to support effective implementation. More than 1,000 of community-based pharmacies have closed their doors past 2 years, including 347 Rite Aid locations, causing the substantial disruption in care. As OCA proceeds the rural health transformation application, we emphasize the holistic model of fully integrate the pharmacy into the care network. Pharmacists delivers far more than dispensing. They do comprehensive medication management for chronic care management, prescribing and prescribing under the standard of care, transitional care, and more. Aligning with the alternate payment model to improve outcomes and to lower the cost of care. CPHA also has pharmacists serving at the CareRx advisory efforts affordability of the insulin. Pharmacies should be included into outsets of the initiative like this. They cannot succeed at scale to fully activate the pharmacy network and real-world data. Workflow input to the pharmacist should be informed advisory deliberation. Pharmacies remain in the most accessible and affordable entirety of the point of care. We appreciate OCA's leadership and transparency and affordability. Look forward to collaborate to ensure the reform and implement effectively. Thank you so much for your consideration.
Thank you. Next up at the podium.
Hi, good morning. I'm Victoria Valencia from the California Hospital Association. CHA recognizes that there are clear opportunities to improve cost effectiveness and affordability in healthcare. The CHCF recent article points to promising areas, including reducing administrative complexity, improving care coordination challenges, and strengthening timely preventative care. On pricing, there was a 2019 JAMA article cited within that CHCF article that highlights that pharmaceutical pricing is a major area of concern, and we applaud OCA's steps that they are taking in HCI to address these challenges, including the efforts to expand low-cost insulin access to all Californians. We urge the office to address PBM issues and examine insurer consolidation, which ensures leverage which raises insurers' leverage of workers' premiums and results in narrow networks and reduces care. And we also appreciate the conversation that the board members had around streamlining care access and in ways that reduces administrative burden for patients. Unfortunately, I think patients are the ones that ultimately carry that price. And we also believe that that contributes to a lack of access to preventative care as well. On the MLR article, we appreciate OCA's referencing the 2025 September Health Affairs article by Michael Bailett, an article which we highlighted in our recent letter to you. The piece describes growing vertical integration of large insurers that allows them to inflate their profits and basically reduce their MLR refunds. The article raises questions about the sufficiency of OCA's approach to overseeing health insurer profits. Since the office is relying on these MLR articles, which there are clear and documented deficiencies. We urge the office to further examine the sufficiency of this current approach and evolve as necessary to ensure premium dollars are being spent appropriately.
2 minutes.
Lastly, the Health Affairs article on health pricing and the real-world impacts of such policies. In August 24, 150% of Medicare rates were floated. Using HCI data in our October 2024 letter that uses such a cap, we did an analysis where we showed that it would cause nearly 80% of hospitals to operate in the red, dropping statewide median operating margin to negative 10%. And forcing operating changes that result in nearly 60,000 jobs lost. Clearly, such an approach would be devastating for access to care without a direct effect on the premiums that working Californians pay. Thank you.
Thank you. There are no more raised hands from attendees remotely and no one at the podium. So that concludes public comment, and back to Dr. Hernandez.
Great, thank you. We'll now consider action items for consent. I believe, Deputy Director Pagani, that we have August minutes. Is that all?
Yes, we have the minutes. The minutes, as well as the written public comment received since our last meeting, have been distributed.
Great. Can I get a motion to approve those minutes from somebody?
So moved.
Dr. Pan? Ian, great. We have a motion on the floor. Any comments from the board, questions from the board? If not, we'll open it up for public comment.
We're taking public comment at this time regarding the minutes. There are no raised hands virtually, no one at the podium.
Okay, we're ready for a vote, please.
All right, Dr. Sandra Hernandez.
Aye.
Richard Cronick.
Aye.
He says aye. Ian Lewis.
Aye.
Elizabeth Mitchell.
Abstain, I didn't attend.
Okay. Richard Pan.
Aye.
Noting Secretary Kim Johnson is not attending. That completes roll call for minutes.
Great. I believe those minutes are approved. We would now like to turn on the agenda to item 5B, spending target enforcement. I think I'm going to turn this over to Michelle, yes?
So I'll be covering spending target enforcement. We'll be discussing assessing performance, technical assistance, and public testimony. So starting with technical assistance. Just go one more slide. So OCA's statute says the director shall enforce the spending targets and may take progressive enforcement actions, including providing technical assistance to help entities come into compliance. Next slide. The statute also says when an entity exceeds a spending target, the office shall notify the entity of their status and provide technical assistance. It lays out some process requirements like giving the entity 45 days to respond to the notification of their status, which allows entities an opportunity to provide additional data and information. The statute also says the office shall consult with the Director of Managed Healthcare, the Director of the Department of Healthcare Services, or the Insurance Commissioner, as applicable, prior to taking enforcement actions to ensure any technical assistance, performance improvement plans, or other measures authorized by this section are consistent with laws applicable to regulating healthcare service plans, health insurers, or a Medi-Cal managed care plan contracted with DHCS. Next slide. So we've shown this enforcement process flow before. So we've highlighted where technical assistance takes place in the larger enforcement process flow. Technical assistance takes place after an entity receives a notification of their status of exceeding the target. And then we assess performance. And then after technical assistance, we have a decision, in terms of OCA, have a decision on whether to proceed with other steps in progressive enforcement. So taking us to our next slide, what is technical assistance? So I want to share some information on how OCA is defining technical assistance. Technical assistance for the progressive enforcement of spending targets is information provided to healthcare entities to support their capacity to meet spending targets. The technical assistance will be a letter to the entity who exceeded the target, providing them with resources they could employ to assist them with coming into compliance with targets. These resources may include research studies, literature, information about models for increasing primary care investment and APM adoption, and cost-reducing strategies that have been presented to the board. Letters may be tailored by healthcare entity and may decompose areas of excess spending. Technical assistance does not mean OCA will direct an entity to implement specific changes to their operations, or OCA staff serving as a management consultant to a healthcare entity. So I want to take us to the discussion portion. So as I mentioned before, we have a yellow arrow on the slide. So this is a informational item and a decision item for OCA. We're looking for discussion and feedback on technical assistance regarding how we're defining it and how it fits into the enforcement process.
Thank you, Vishal. Open it up to the board. I know we've talked about this question of what does technical assistance look like, so I appreciate you coming back with that. Comments from the board? Dr. Pam?
So I mean, this question about, how we define it, I guess the question to me is, in addition to how we define it, is what's the consequence of either following or not following technical assistance, right? And I guess it depends on how vague or specific it is, so we have an entity, they exceed the cost target, they say, okay, what do I need to do to address this? We provide technical assistance, they follow the technical assistance, they're still over the target, then what? So hopefully we will, if we're not getting to the question now, hopefully we will get to that question, because that becomes really important, right? We're in this role of providing assistance, and also we're also the enforcers as well. And so what exactly does it mean when we provide technical assistance and they follow it to the best efforts? Let's put it that way. So depending on the nature of the technical assistance, it may be difficult to implement or not, but I think to me that's part of the question. So this definition of technical assistance also, I think, is tied to what the consequences are for the entities that either just choose to follow or not follow the technical assistance we provide.
Yeah, I could clarify that. So if we provide technical assistance, it doesn't mean we therefore wait for the entity to implement that technical assistance, because we would essentially be in a kind of forever it would essentially be an elongated period where we have to wait for them to implement the technical assistance. So there could be a scenario where we do give technical assistance and we don't go to a PIP. So in that instance, they could have an opportunity to take in that technical assistance. But in the scenario you're referencing, where we would kind of wait to see how they implemented technical assistance, just wanted to clarify that's not how it would work.
Elizabeth?
I had a question about, you've listed the resources, research, literature, et cetera. Are you identifying organizations that do technical assistance that are independent from HCI as well? Like, there are expert organizations out there that are doing this.
Yeah, so we're not providing kind of, here's consulting services you could use. We would want to highlight models that are effective, and the entity would need to take in that technical assistance, and then kind of, they're going to have, they're kind of the most well versed in kind of how their organization operates and how they would go about meeting the spending target. So they could, that could be a follow-up from them to kind of, if we were to provide information about advanced primary care practice models, we would include citations to those models, and they could on their own reach out to learn more about them, or from other peers or other strategies that we have brought to the board, like the cost reducing strategies. They could do their own follow-up.
Just Dr. Pan, I mean, back to your question, as Vishal noted, I think the technical assistance, which is the term used in the statute, is more high level and broad. We don't have specific enforcement authority in the statute to enforce whether an entity does or doesn't implement the suggested steps. And so I think that technical assistance is more high level, and the PIP is more a particularized set of strategies for a specific entity, but the technical assistance really isn't. And it's not until we have an entity that doesn't comply with the PIP that we would get to something like that we would get to penalties.
So just to clarify, whether or not technical assistance is taken up, if we think a PIP is in order, we will proceed with a PIP that's very specific to those institutions. Is that correct?
That's correct.
Okay. Richard, please.
To clarify, I don't think it's, if I understand it correctly, it's not right to say whether or not technical assistance is taken up. And Richard, to your kind of question, there's not really a question of is the entity sort of following or complying with the technical assistance, because the technical assistance is not so specific. It's a very sort of general set of resources, but I think if I understand it correctly, there's not a, you couldn't answer the question of did the organization follow the suggestions of the technical assistance, because the TA doesn't have suggestions per se, or it's got a very broad set of suggestions.
Yeah, nor would, I mean, there is no reporting requirement for an entity to come back and say, yes, we did X, Y, or Z. So we frankly won't necessarily know whether they have.
Yeah. And one question is, has this been shared with the advisory committee yet? So
we've had an introductory discussion with them, and we're going to, whatever we show here, we tend to show to them. So in the January meeting, we would present this content.
But no feedback yet.
They'll see it before.
Not on this content.
On this piece, yeah.
Dr. Pan, do you want to say something?
So as we go back to the enforcement process flow, so my understanding from what you're saying is that, they're offered technical assistance. It's not necessarily particularly tailored to that entity, but then there will be a performance improvement plan that is.
Yes.
Correct. Okay. So, I know we're not quite at the performance improvement plan. Then I guess my questions now start to apply to the performance improvement plan. Okay, if that's a tailored, specific thing to organization that we're saying, hey, you're over the target, you need to follow this, then I think at that point, though, I certainly hope we are, if it's a tailored, specific response to them being over the cost target, that we are monitoring whether implementation, and if they are implementing it, and they're still over the target, that needs to be taken into account, right?
Yeah. There's the performance improvement plans have a specified time period of up to 3 years. That could be extended. And the specific, I'm using the word milestones, but the specific strategies that they need to implement, they would need to be quantifiable and measurable. So we would be monitoring for that.
Okay.
And Michelle, go ahead.
Just one follow-up. So while the PIP, the performance improvement plan, is very specific to the entity, I presume, maybe it's just check my presumption, that while the technical assistance may not be specific to that entity, there will there is probably hopefully some relationship between the PIP and the technical, and those are obviously if the performance improvement plan is more specific to the entity, it probably should still, well, what we provide for technical assistance should be the pool from which we draw from that's tailored to that specific entity. I mean, otherwise the technical assistance isn't very helpful, right? It may not be specific to the entity, but it would be a set of things that we would probably draw from to say, hey, for your particular organization, these are the things that you should particularly focus on, because that's what we're seeing in your organization that you might have more of a challenge versus more general, here's a list of things you can do from the technical assistance standpoint. Correct?
There wouldn't, there's going to be overlap, but I wouldn't say that technical assistance is the full universe of everything, because the PIPs are so specific to each organization, and that's going to involve dialogue with the healthcare entity to understand what the areas of excess spending are, and kind of what the levers are and potential strategies. So they're similar, but they're complementary, but not necessarily the same.
Richard?
Maybe kind of jumping the gun, but I had imagined the performance improvement plans, as Vishal said, coming out of a dialogue, but largely coming from the healthcare entity to begin with. I would not imagine OCA staff going to a hospital or a medical group or some other healthcare provider and saying, this is what you should do to reduce your spending, but rather the entity saying, okay, we understand we need to reduce spending. Here are our thoughts about how to do that. Does this work on your side? And I'm sure, I mean, they'll be back and forth on all of this, but and I don't, as talented as Vishal and staff are here, it doesn't make sense to think that folks in this building are going to go to some entity and say, this is what you ought to be doing.
That's correct. We would, the healthcare entity would propose specific strategies, and then we would review, and we would, check that those strategies, how they stack up against the guardrails for access, quality, equity, workforce stability. And then we would have that dialogue with the healthcare entity before we approve a PIP.
Richard? Go ahead, Ian.
Just trying to wrap my head around this a little bit. I mean, the different buckets of technical assistance, I imagine some of it will be comparative, especially with the emphasis on pricing. There will be academic expertise that we could draw on, and then there'll be anecdotal experiences of other actors in the market that we've learned from. Am I capturing those right? And then a second related question is, since at least all of that would be in the public domain, is the technical assistance that we provide particular entities also in the public domain?
Public domain in terms of things they could do?
In terms of transparency. Public
transparent. Yeah. In terms of OCA sharing the TA letters?
Yes.
Okay. I'm not 100% sure about this, but so I'll have to. We'll circle back about that. I don't expect there to be any issue with posting it, but Sheila's coming up.
Sheila, please. Thank you.
I think this is on, right?
Sheila, introduce yourself, please.
Hi, I'm Sheila Tatayan. You know, I'm the Chief Counsel for OCA and the Assistant Deputy Director for Compliance. So with regard to the technical assistance, remember that the plan will be notified that they are not in compliance with the spending target, and they will have 45 days to respond. So we talked about how it's very specific to the particular entity, and that also goes to the question of what's public, because there may be some things that are confidential relating to what they can do to improve their spending performance that we would not be able to put in the public domain. Our statute has some very specific requirements on confidentiality laid out in 3 different sections. So we have to be very careful about what's considered public and what's not. So the statute talks about certain types of information that would not be public.
But technical assistance that is broadly available in the public domain would not have any restrictions by statute. Is that correct, Sheila?
Yes, yes. If it's already in the public domain, or if we're just talking openly about strategies that come from studies or from the experiences of others that we've discussed before, yeah, that's public domain.
Super. Thank you, Sheila. Dr. Pan?
I just heard you say that technical assistance is specific to the entity. That's not what we just talked about before. Can you please clarify that?
Yes. So we won't be having technical assistance that is so detailed, specific to the entity. But for example, when we talked about broad strategies, not all strategies will apply to all entities. So when we talk about what would go for the entity, we would try to identify what are the most applicable technical assistance items that would work for that entity. That's what I mean by the specificity.
Okay, so I'm going to follow up, which actually leads to the question I was going to ask before you even presented, which is that back to my comment about, well, if ultimately the entity in their PIP, right, and that's, frankly, that's going to have to be, I assume that's going to be more of a dialogue. I mean, I get when you said, oh, well, the entity will propose and we will review, but I'm sure we will comment and then there'll be back and forth, right? Let's be honest about this. This isn't simply they submit and we go, oh, okay, that's your PIP and that's it. We will comment and there'll perhaps be a dialogue, and I guess we will, I don't know if the word is approve or not, or sign off on it, right? So we will get to that when we talk about the PIP, but back to my original question about, well, now, yes, the entity will know hopefully they know themselves well enough, but I presume part of the reason for technical assistance, and even the somewhat tailored technical assistance, even at its high level, is that we want that technical assistant is to hopefully inspire or inform the entity in helping eventually develop their PIP. So that's back to my comment about, well, the technical assistance is something from which the entity would draw from to develop their performance improvement plan. Is that not correct?
Well, at a highest level, in terms of meeting the spending target, you could either implement changes in prices or implement changes in utilization. So that the technical assistance letter would kind of broadly speak to those 2 levers in terms of impacting total spending. So kind of at that level, like the PIP could also include items like how are you going to change prices, or what are you going to make, what are you going to propose for changes on the utilization side. So that's kind of how I would see those 2 kind of relating to each other.
I think you're correct in how you're envisioning the technical assistance overlapping with the performance improvement plan, because the performance improvement plan, as Dr. Kronig said, it really is coming from the entity. It's their corrective action plan. They've been informed that they've exceeded the target, and they now have to tell OCA how are they going to come into compliance. So it's a corrective action plan. So we would expect that they would incorporate some of the strategies in technical assistance to show us how they're, that's applicable to them, useful to them, and what milestones they would meet, because that's the performance improvement plan is our way of monitoring what they're going to do to come into compliance. And if they don't, it's our way of enforcing their non-compliance.
I appreciate that response, because I think as we're talking about this, to me, in some ways, the technical assistance is our first sort of like on the table. These are the things you should be thinking about. Now come back with us with your specific performance improvement plan.
Yeah. Correct.
Okay. Well, so that goes back to what I was asking before. It sounds like is that, yes, the technical assistance, which is somewhat tailored to the entity, would be from which we would provide our suggestions that the entity would draw on to say, this is what we will more specifically do to try to show that we will try to meet the cost targets in the future. and then we can have a later discussion about what's the consequence if they actually implement their PIP that we signed off on. Thank you. Elizabeth?
Just quickly, and I can envision, entities not necessarily wanting technical assistance from their regulator. So I am, one of my questions, what I was trying to get at is, and there are lots of entities and examples out there of ways to improve workflow or efficiency or, team structure to reduce overall costs. I agree that it is not our responsibility to make that known. But one of the things I've been really struck by in the last 3 years is that I haven't heard any ideas from the hospitals on how to actually reduce costs. So I just want to make sure that, as those studies or lessons are known, if we will make those available, or again, is that just, we're basically saying you need to hit this target and we will check in if you're compliant. I guess I'm trying to understand. I understand we may not be doing all the technical assistance, but is there anything else we might do to enable it?
We are, in terms of promoting strategies to slow down spending. We have our APM work stream. We have our primary care work stream. So we are doing things. It's just specific to the organization and how they, what specific actions are going to take to increase primary care spend. We could put out guidance in terms of what are good models and for APMs as well. We have the APM standards, but the performance improvement plans are so unique to each healthcare entity that the technical assistance letter would be at a much broader level, and it wouldn't be the full universe of everything that's possible that we could put in a PIP.
Okay, if there's no other questions from the board, I want to welcome Don Molds, who joined us. Thank you, Don, for joining us. Let me open this item up for public comment, please.
We'll take public comment at this time on agenda item 5B. Please keep your comments to 2 minutes or less. We'll be looking for individuals who approach the podium and those attending virtually who raise their virtual hand. First, looking online, there's no virtual raised hands. I'll turn to the podium.
Beth Capel for Health Access. It's good to hear this discussion developing about how the enforcement will work. I would want to keep open the possibility that any technical assistance that was provided might perhaps be tailored to the type of entity. A hospital would require different TA than a health plan or a large physician organization. A large hospital might look different than a small rural hospital. So I would think in that sense, there would be some tailoring. I would also think, to speak to board member Elizabeth Mitchell's point, that that the staff and those of us who are paying attention would want to be open to the possibility that a healthcare entity might suggest some things that the staff had not thought of when they provided the technical assistance. And so I would not want this staff or this board to limit what could go into a performance improvement plan to only those things listed in technical assistance, because there might be good ideas out there that had not yet surfaced in the publicly available literature that might actually be innovative. We will look forward to the discussion on the PIP. I want to also second what Sheila Tatayan said about what's public and what's not. There was a lot of thought given to that in the law. There are probably a few more places that we'd like some transparency, and we will ask for them and be clear which ones are required by the law and which ones are merely a good idea from our perspective. Thank you.
Thank you. Turning to a member of the public who is virtual, Steve Shordell, we're unmuting you on our end. Please unmute and go ahead.
Yes, I'm a member also of the OCA Advisory Committee. Just a brief suggestion, interesting discussion in terms of performance improvement plans. I think everyone knows a number of other states have already had experience with some of these, Massachusetts and others, and it would be good, of course, to try to learn from that, what they've learned from that experience, and and so on. So just one suggestion.
Thank you. Seeing no one at the podium and no more raised hands virtually, that completes public comment.
Let's see, Vishal, should I give this back over to you to continue?
Yes. So the next portion of this agenda item is public testimony. So the statute says the director shall enforce the spending targets and may take progressive enforcement actions, including requiring or compelling public testimony by the healthcare entity regarding its failure to comply with the target. So going on to the next slide. So this is how OCA is defining public testimony. Public testimony is an optional step in progressive enforcement at the discretion of the director. Public testimony is an opportunity to hear from healthcare entities that have exceeded the spending target. It can take various forms, including in-person or written testimony. This provides a chance for entities to elaborate on why they went over the target. So moving on to what public testimony is not. So it's not an invitation for entities who are meeting the spending target to explain what they are doing. We can invite these entities to our meetings, but they are not required to comply. And then public testimony is also not asking entities to explain how they plan to meet the target in the future because of the way that the statute describes public testimony as applying to entities that exceed the target. So going on to the next slide, so we're looking for some discussion and feedback on this item, specifically under what circumstances would the board want to hear from healthcare entities regarding why they exceeded the target.
Dr. Pan?
So I think providing public testimony, whether it's a presentation or something in writing, is an opportunity for the entity to explain. How's that tied into any sort of waiver process we have, or the PIP or so forth? So I don't see public testimony as being punishment, right? So I don't think we should view it as that. It's an opportunity for an entity to explain whether they want to avail themselves or not of that opportunity. It's up to them. But I also wanted to note, like, how does that tie into other parts of, essentially enforcement later on, whether it's waivers or PIP or other mechanisms that we have in place in terms of what they present, whether in writing or in a presentation.
So waivers are a separate piece.
Vishal, your mic's not on.
Thanks, Dr. Pan. So waivers are a separate piece that's kind of on its own track, and I'll be going over that in the next portion of this presentation. But in terms of the progressive enforcement, there's technical assistance, public testimony, performance improvement plan. So there could be a scenario where we've given the entity TA. We also bring them at the discretion of the director. They could come and publicly testify at a board meeting, or they could submit a written letter, and then kind of that's it. And then that kind of ends, and the entity doesn't go on to a performance improvement plan. There could be situations where they do. So it really depends. But it's not always required that they have to do each step of the progressive enforcement process.
But I do choose to provide public testimony. I assume, first of all, it would be on the record in some ways, right? And so, well, yes, the waiver, and maybe on a separate track and so forth, is it going to inform any of the subsequent actions or decisions that we're going to make, whether about some of these other mechanisms? I mean, they're going to take the time to present. Is it simply, it's not just, hopefully it's not just an exercise of okay, I'm trying to explain why, but that we then take that information, whether they provide any new or not information out that from what you already have, at least they're now providing it in this, public way, right? Whether through letter, again, presentation, will that be used in any way to inform subsequent other decisions about other parts of the enforcement mechanism or waivers or so forth?
So waivers would happen before, waivers are an optional step, and I'll be covering this. It's an option for the office to implement, and that would, that would precede all of this. A public testimony wouldn't be part of the waiver process if OCA were to implement that.
So, you have a follow-up, Dr. Pan?
Yeah, I guess we may make policy decisions about who or what reasons will give waivers. They may decide to choose to present to make the case that they actually qualify for one, right? That for some reason we decide not to. I'm just trying to clarify.
But Dr. Pan,
yeah,
an entity could always submit written testimony. An entity could always come and testify to the board, really at any point. That process of public input, whether it precedes a waiver or not, that's always a prerogative, it seems to me, that these entities have with regard to the board and their public
well,
testimony.
So let's put this. I mean, obviously anyone can testify in public comment for the 2 minutes that we provide them, but this sounds to me to be more than a 2-minute. I mean, this is a more formal presentation, and I assume that our staff or our chair will make decisions in terms of looking at our agenda, whether to say, yes, we want you to, because, I mean, think about how long each one is, how many we want to do, right, in terms of our agenda. So, so I'm just trying to figure out how this presentation, this public testimony, fits into the rest of the universe of our enforcement mechanism, right? It's not, hopefully it's not just an exercise of, okay, come present, and then that it just ends there. The testimony should inform.
And I think that's the discussion we would like to have, and to have your input, because it is an optional step, and it could be written in oral. We have more than 50 health plans, more than 400 hospitals, and goodness knows how many physician organizations in the state of California. We don't yet know how many will exceed the spending target. So I think, right. So I think there is also a logistics issue with the notion of oral testimony, but wanted to hear your thoughts as we consider that.
Rick?
To the question you asked us to answer, under what circumstances would the board want to hear from healthcare entities exceeding the target? At least a kind of written response. My answer is under any circumstance. I mean, I'm always going to be interested in reading the response from healthcare entities about why they exceeded the target. And I imagine that, as Dr. Van said, most healthcare entities exceeding the target will be happy to provide voluminous documentation of why. And then I think, the question of under what circumstances might we want something more than 2 minutes at a board meeting, hard to answer now, probably under the circumstances under which we are thinking about moving towards a PIP, or circumstances where there's something particularly interesting going on. I don't feel, the general answer is probably limited given time constraints, et cetera, but so I'm always going to want to read it, and I might occasionally want to have a longer discussion.
Yeah.
Yeah, and I very much agree with that. I think there are two different cases that I would really emphasize public testimony. I'd love to see written testimony from everybody, but given the limits on time, certainly if there are egregious cases where staff are having a hard time working with an entity, that would be a case that I'd really want to hear from the entity why that's going on. But also, the other category is not just from an enforcement perspective, but to inform the board, and you'll have a good sense as staff of the entities that exhibit unique or uniquely important lessons, object lessons for us, whether it's by market or provider type. Or other categories. I myself have got a lot out of individual entities who've come here and presented, and also got a lot, for example, in the discussion we had in Monterey and the focus in that market. And that gets me to my last point. I don't see this just as an opportunity for the entity to present, but for the members of the public to bring forward the way in which our engagement on this does or doesn't impact the affordability of healthcare and the quality of healthcare in their community, and that'll inform where we focus our efforts going forward.
Thank you, Anne. I just wanted to comment on this notion of an entity being invited by the director to come and do a public presentation, however long we decide that to be. In that situation, if an entity were invited and opted not to come, I assume the board would know that. I mean, this is described as a discretion for the director to decide this. As an invitation, I assume we would invite whoever you think is appropriate to do that. And if they opted not to, I assume that the board would know that. Is that correct?
We'd expect
hold friends.
Dr. Hernandez, we'd expect healthcare entities would take the opportunity to come and.
I would hope so.
Yeah.
I would hope so, but I just want to understand the circumstance under which they might choose not to.
So remember that these are enforcement steps and they're progressive. So we talked about technical assistance. That's the first step. Public testimony is the second in order of the steps, and the director would require or compel an entity to come for public testimony. So it's not an invitation to say, tell us, or come and talk to us. It's a step in the enforcement progression. So it's a require or compel. So if they refused, they would be out of compliance.
And our remedy for that might be what?
Because it's part of our progressive enforcement, and we do have in our statute a willing and knowingly standard. So if they're knowingly failing to comply, willfully refusing to come, and when we've compelled them for public testimony, we could issue administrative penalties.
Super helpful. Thank you. Mm-hmm. Don?
And I apologize because I got in this a little bit late.
Todd, turn on your mic. It's good. Yeah.
And I can't. Oh, there we go. Glad it wasn't me.
Still you, Don.
That was me, just to be clear. I guess, as I said, I got into the conversation a little bit late. I did look at it. But so the scenario here is that an entity misses the target. I had assumed that this would be sort of an open opportunity to come in and talk about the why and build the case for it feels, and maybe this is wrong, but I'll throw this. It feels a little bit unhelpfully punitive to force them to come in and explain why. I mean, I totally get it. It seems like the right thing to do, potentially, to have a conversation about what happened and what an entity is doing to rectify, but to compel them to come in and talk about why they missed it when essentially what they're doing is they're saying, okay, we're going to pay whatever penalty is enforced. It just seems weird to pile on penalties on top just because somebody didn't show up. It feels a little bit like getting called into the principal's office. I will say that. And that just, it doesn't, I don't understand the function that serves.
This is a helpful discussion. So let's step back for just a minute and think about the process. So when an entity fails to meet the spending target, they're going to be notified that they've missed the spending target. They have 45 days to respond, and in that response, they can choose either to explain why, or they can also make their case for a waiver. That's in the statute, all right? So that response won't necessarily be public, okay? So while we might choose to publish something about the response, there may be some items in their response that are confidential, and we could not, by law, put that in the public domain. So again, they'll have a chance to respond once they've been notified that they missed the spending target, all right? And then when OCA decides that it's going to enforce against an entity, like I said, the first step would be technical assistance. The second, on public testimony, is a discretionary item that the director can decide. So yes, I see what you're saying. It does feel punitive to call them in and testify, but that will be up to the director. And, in this discussion, we could talk about what that would look like, and I think that's what the questions are here today. What do you think you want to hear in public testimony? Is it valuable? Should it be very targeted? Should it be like a hearing where you have a on-the-record testimony?
It still feels like it's an extra step without a purpose. I mean, I understand the opportunity, but compelling someone with additional penalties if they don't come and state their case, particularly if it's in a public setting, and so if is the goal to force the conversation into a public setting, because that's also a big additional step if that's what's going on. I don't understand the why if somebody, and it's a small point here, but the why if somebody, if an entity is saying, we're not effectively what they're saying is we're not gonna disagree with this, or we're gonna disagree with it but not push our point in public. If it's to force the conversation into public, that has different implications. If it isn't, then I don't understand the purpose of it.
And public testimony could also be in writing as well. So that's another option. So what I'm hearing you say is that you feel like you're not sure there's a real value in it, and it feels punitive.
That's not quite what I'm saying. I'm saying the opportunity has a value,
okay,
but the compelling is problematic.
Okay.
Yeah, Dawn, it's also in the law. Like it's we have the authority to compel. So it's.
But I just want to come back to a point that Ian was making, which is depending on where this entity is, there could be consumers, folks in that community that actually would like to actually hear and respond to whatever that entity has to say in a public domain. And so I do think I'm not saying we would do this on all circumstances. And by the way, I got to imagine that anybody who had the opportunity to come explain why they were overspending target would want to do that. But I do think there's a value to compelling someone to come. And if they don't come and there's desire by the community and the public to hear it, I think having a remedy for that is reasonable. That's just my own point of view. Yeah.
Yeah, I mean, and this gets back to your question about whether we would know if an entity had been invited and chose not to come. I would urge us to hold that hearing anyway, because there are members of the public who ought to have that opportunity to comment, even if they don't take us up on the option. And we can decide, or you can decide there, whether then to compel or not.
And the remedy of an administrative penalty is discretionary. I mean, you asked what would happen, what could we do? You are compelling them to come if they refuse. It's a discretionary step if you want to issue a penalty.
Rick, did you want to weigh in here?
Yeah, I mean, I think we are in agreement that providing an opportunity, at least in writing, we all agree to that.
Totally.
Under some circumstances, an opportunity to present publicly makes sense. I think I'm with Don that, a penalty if they decide not to, we got enough other things to worry about here, and kind of worrying about that and what that penalty should be and all that. not as important as moving towards performance improvement plan and actually making progress.
Dr. Pan.
So, and a question for you, I guess. So what I'm starting to hear is that the reason someone might be compelled to present publicly is that we might have some entities who might have an interest in the inner workings of this entity and maybe perhaps request this office or the governor or someone politically to have a public hearing so they can call them out. And perhaps also, I guess the question is that in this public hearing or written submission, we have parts of the law that say certain things are confidential. Will people be allowed to ask questions about things that technically should remain confidential under the law in terms of what they submitted to us? Because that's maybe why they want to have the public hearing, is to pressure them to reveal information in the public setting.
We would not, because of the strong confidentiality provisions that are in the statute that apply to OCA staff, the board, we could not ask questions.
I guess in a public hearing, I mean, we may not be able to, but someone in the audience could. I guess they don't have to answer
They don't have
it.
to respond.
Right, they wouldn't necessarily have to answer. And I don't know if we envision people from the audience asking questions in public testimony.
Probably not. Okay, any other comments from the board on public testimony? Michelle, you want to take public comment now? Or you want to go on with a waiver and do both?
Go on to waiver.
Dr. Pan?
Sort of going back to the original question is, which is under what circumstances would we want to hear from healthcare entities? So I don't think we quite answered that question, or at least, I don't know, have you gotten sufficient input? I guess one of the questions is, for example, what parameters will we set in general? Because obviously, you know, in which we would actually ask someone to provide public testimony. I guess I've heard everything from like, okay, well, perhaps everyone should just supply something in writing anyway. And I assume that because this is public testimony, that whatever they submit in this case is actually open to the public. It would be, it's called public testimony. So I assume anything they submit in response would actually be something that one could post publicly or be available to the public. Maybe I should pose that as a question first.
Yeah, that's correct.
Okay, what we're going to do is let's go on and have the discussion on waiver of enforcement, and then we'll take public comment on both of the above. Okay, Michelle, please.
Yeah, if we could go back one slide. So just to close out the timeline discussion. Slide 48, yeah, okay. You know, this is the timeline for future discussion. We'll continue with TA and public testimony until through the end of the year. We do have slated for January and February discussion of performance improvement plans. You know, this timeline's subject to change, so there's a chance that we could bring those topics to you sooner. And then the rest of the timeline goes on to you know, when we would discuss penalties as well as the rulemaking process. So moving on to waiver of enforcement. So the statute says that prior to taking any enforcement action, the office shall notify entities that they have exceeded the target and give entities not less than 45 days to provide additional data, including information in support of a waiver. The statute also says the office may establish requirements for healthcare entities to file for a waiver of enforcement action due to reasonable factors, anticipated, there's kind of a list of items, reasonable factors, anticipated costs for investments, initiatives to minimize future costly care, primary care, and then extraordinary circumstances. The statute also lists examples that I just read and outlines some process requirements around submission and approval of waivers. So you really have to read these two provisions together to understand that the waiver process is is an optional provision that the office could establish. And then taking us to the next slide. So I want to cover the difference between enforcement considerations and reasonable factors. Enforcement considerations are factors that OCA can consider during progressive enforcement. Specifically, these include each entity's contribution to cost growth in excess of the applicable target, any actions by the entity that have exceeded or are likely to erode access, quality, equity, or workforce stability. Factors that contribute to spending in excess of the applicable target, and it's specifically this bullet point about factors where we elaborate on the enforcement considerations. The extent to which an entity has control over the applicable components of its cost targets. And then moving on to the right side of the table, which is the waiver, reasonable factors that are under a waiver. So these include reasonable factors outside the entity's control, such as changes in state or federal law, or anticipated costs for investments and initiatives to minimize future costly care. An example is given for primary and preventative services. And then the last bullet about extraordinary circumstances. So going on to the next slide. So, in our last board meeting, we discussed this list of potential enforcement considerations. So these are factors or circumstances that OCA could consider when determining which entities would proceed beyond technical assistance to public testimony, performance improvement plans, and /or financial penalties for a given year. These considerations will not change or modify an entity's reported performance or directly exempt or waive an entity from enforcement, each year. And then taking us to the enforcement process flow. So this is, as we've shown here highlighted, is where in the enforcement process flow a potential waiver could be situated. There would be discussions on reasonable factors, anticipated costs, and extraordinary circumstances. If a waiver request is not approved, the entity would continue to the assessing performance phase. Next slide. Again, we have a yellow area to denote that this is a decision for OCA, and we'd like to discuss this with the board and public. So OCA's current thinking is that we would not implement a waiver of enforcement at this time for healthcare entities who fail to meet the healthcare spending target. And this is because the list of factors under the waiver are duplicative with the factors that OCA can consider under enforcement considerations. So as part of the process to assess an entity's performance against the target and determine if they proceed to the next step in progressive enforcement, OCA can assess the very same things that are under the waiver, which are reasonable factors outside an entity's control, anticipated costs for investments and initiatives, and extraordinary circumstances. We do note that after several years of measuring, reporting, and enforcing spending targets, we'll gain experience. So, based on that experience, we can learn if a waiver of a performance year is warranted for specific conditions and circumstances that an entity experiences. So with that, I'll turn it over to the chair.
Questions or comments from the board? Dr. Pan?
appreciate the presentation. I guess a couple questions in terms of the waiver is not simple. Well, presume that a waiver does not have to be like, oh, we just it's a total waiver. You could have partial waiver. You could say, well, the circumstances would basically lead to potentially, let's say, a certain, increased cost or whatever, and if you're within that, or something of that nature, right? We can put boundaries on the waiver, right, in terms of how much latitude. If someone's like completely overshot, like that, whatever we gave the waiver for, that alone cannot explain that, and you would still be, it might give us a little more latitude, but not necessarily say that if we create a waiver for X, anyone who fits X, there's no limit. Absolutely correct.
No limit in terms of their
cost. Yeah, the cost target. Right. In other words, it's not a total waiver of the cost target, right? We could say, well, we might give you a little more latitude because this is an act of God, which would lead to increased costs, et cetera, in a certain range. And we would say, okay, well, we're not. I think the purpose of the waiver is that, especially if you have, and appreciate you pointing out that there's some duplication with is that if you had something that affected a lot of entities, right? Let's say there was a big earthquake and there's a whole bunch of hospitals that instead of, we could go through each specific hospital and say how much damage did you have, et cetera, but we might create a waiver that says, look, if you're affected by this act of God, right, in this area, we'll give you a certain amount of latitude because we know that effect, so that you're not trying to we're not having to do an individual thing for every single entity if there's a lot of entities that might be involved by the same event.
Yeah, if I'm understanding you correctly, under enforcement considerations, we have the ability to consider those extraordinary circumstances and kind of supported by data and information that something occurred, and we could kind of not have entities go through the additional steps in the progressive enforcement process. But under a waiver process, each entity would have to apply, and then we would have to approve. So there's a bit more.
Well, yes and no. I guess a waiver basically would be a process. Yes, they would have to apply for it and justify that they met the waiver. But that, and again, maybe you want to correct me. I think that is an opportunity to not. Basically, we could either catch them on the enforcement side and say, oh, by the way, right? But if you have something that affects a lot of different entities simultaneously, some act of God, right? Let's say, that hopefully the waiver process would be one that basically decrease the workload of trying to go and, measure that for each individual one through the enforcement process. We could say in the enforcement process, okay, well, we will give you some latitude because et cetera. But if you have something that's affecting a lot of entities, I presume that's also why you said, after you have several years of reporting, you get a sense of like, oh, okay, maybe we can do a waiver for something because now we have a sense of what the pattern is, right?
Yeah.
So so the waiver hopefully is a more simplified process than instead of having each of those entities have to go through an enforcement process, and then through the enforcement process we say, oh yes, we also recognize it. You said there's a lot of duplication there, and then say we'll incorporate it as part of the enforcement process. Correct?
Yeah, potentially in the future, we're depending on what we learn from experience, then we'll have a basis for having a waiver program.
Sheila, do you want to add something to this?
It's a waiver from enforcement. So I think you were asking, do we waive them from everything? It's sort of like a grading. No, it's actually a waiver from any enforcement action. So if somebody gets a waiver, it means it's not a waiver from the cost target. It just means that for your performance for this year, you are waived from enforcement. So OCA would not take any enforcement action if they issued a waiver to an entity.
So it's an on-off switch, and basically it's either total waiver, so there's no partial waiver.
Right.
Okay.
Right. And so that's why you've got the chart that goes, looking through the considerations for a waiver and then the considerations for reasonable factors and whether to proceed against a entity. And so, as Vishal and you are pointing out, over the years, there may be a pattern, or we might have more experience in developing criteria that seems to justify a waiver, and that the statute gives us the ability to set out requirements for a waiver.
Okay. Ian, did you have a question?
Yeah, just imagining a situation where an entity missed its target by 1% and filed a waiver saying, well, we increased our primary care reimbursement rates by 20% and that explains it. To me, I would want to see verifiable evidence that that was driving it, not just the claim. Is that how you're thinking that the waiver application would be more seriously considered if it had proof of its claims?
So we have primary care investments as our enforcement considerations, and it's also mentioned in the waiver provision as well. So kind of regardless of which vehicle that factor is implemented, we would want to have documentation, and we would want to. We're having active conversations about if a plan is claiming that, how do we actually verify that the spending is actually going down to the practice level.
Rick?
Can we go back to slide, or go to slide 53, please? I mean, if we're not going to do waivers, to the flow chart one, enforcement process flow.
Enforcement, the next slide.
Yeah, if we're not going to do waivers, this question is moot. But if we are going to do waivers, it seems like it should be, the arrow should be between 4 and 5. That is, you'd want to let the entity provide new data to say, well, actually, we did meet the target. We just gave you bad data the first time, and then consider the waiver. And again, if we're not going to do waivers, it doesn't really matter. But
yeah, I think it's because of the way the statute's written for that, what happens during that 45-day period. There's phrasing that says they submit data information, including information in support of a waiver. So they would during that 45-day period. But a decision on whether the waiver is approved could very well happen between 4 and 5 because we're still reviewing what they sent us.
And then I think more importantly, I think I'm not understanding well, or maybe at all, the difference between the process. If you were to entertain waivers or requests for waivers, the difference between that and the process that you would go through on the in box 5 on the assessing performance. You know, you said that the factors are kind of that you'd consider are the same, and what would be, maybe the question is, how do you envision the assessing performance process to go? And are you envisioning that, you know, for each entity that has exceeded the target, that you will assess their performance and look at, you know, we had a discussion in the last meeting about various factors and make a determination of whether to go on to the next step of technical assistance, which I assume if you were to entertain waivers, it would be a similar kind of process, that your request for a waiver and you'd make a determination of whether to go on to the next step or not.
There's similarities there, except that the enforcement considerations are a broader list of enforcement or factors. It includes entity baseline costs, high cost patient outliers, whereas what's in waivers is kind of a more limited set of criteria, but there's overlap with enforcement considerations. So we would still need to review and assess performance and decide whether to grant a waiver or not, but we would just be granting a waiver on the more specific, those 3 bullets listed, kind of those factors, and not anything else.
And I think I think I understand your rationale for not entertaining waivers, and I think it makes sense to me. But I think I'm not clear on the enforcement considerations part. Do you envision that for every entity for which you send a letter to say you've exceeded the target, that you will make then an enforcement determination and either say, kind of yes or no, we're going on to the next step?
Yeah, we're still fleshing that out, which is the enforcement considerations allow us to prioritize who proceeds along to the next step. So, just using one of them as an example, like entity baseline costs or impact on, taking two of them as an example, impact on consumer access and affordability. Do we want to focus on kind of the largest entities or the ones that have a more dominance in a region or market? And then taking entity baseline costs, do we want to focus on just the ones that have high absolute levels of spending in addition to growth, in terms of prioritizing which entities we take to the next step? So we should always kind of view the enforcement considerations as how OCA goes about prioritizing its enforcement workload.
Yeah, and it sounds like you're working on kind of developing what are the criteria. How would you figure out which entities go from a letter to the technical assistance box and beyond? Yeah. And that you will eventually be making some determination that you may have sent out 200 letters, but that some number of those entities will be going on to the next step based on some process that you've developed to figure that out.
Yes, but I'd clarify that every entity that exceeded the target would get a letter, because that's required.
Yes.
But yeah, the decision on who proceeds beyond TA, that there's going to be a process for OCA.
Elizabeth?
Thank you. I may be misunderstanding, but I feel like we're borrowing trouble for a process we don't have any experience with yet. And I think the No Surprises Act is a cautionary tale where we created a cottage industry for arbitration and dispute resolution that is actually driving costs up. So I know it's not a direct correlation, but it is not dissimilar. And I mean, I can imagine if we invite waiver or offer waivers beyond what the statute has already authorized, we could have a lot of conversations on our hands. And also, I think for the last topic, I mean, we already have the statutory authority to compel testimony. Do we need a separate, more specific authorization? And if so, wouldn't that be through statute and not here? So I guess I'm just wondering how precise and prescriptive we need to be for this compared to what is already in statute.
The public testimony part, that's separate and isn't related to waivers, or it's on a parallel track. So if I'm hearing you correctly, or maybe if you could elaborate what the question is.
I'm not sure we need any action at this time.
Okay.
That's really my point.
Okay.
We're just getting input now anyways, right?
Yeah.
Okay, if there's any other comments, yeah, Dr. Bear?
What I'm hearing you suggest, and I think I'm in agreement with this, is that at this point in time, I think barring since let's say major disaster or something, like an act of God, right? That involves, let's say, numerous entities that where perhaps it may even disrupt their ability to, let's say, even provide the kind of information we might need, but it's clear that that's obviously was out of their control, and so like an earthquake that takes down their data center and stuff like that, right? That we probably would not think about doing waivers and actually use the enforcement process until we have some information or data about what we might want to think about doing waivers. I mean, there's that duplication there in the statute probably was to try to create some flexibility about how we'd approach it. And I think it was also about trying to help, the efficiency, right? If there's something that is a mass event, instead of forcing everybody to march through this thing, you might just say, okay, you're involved in this mass event. We understand how disruptive it is. For this year, you get a pass just because you got to put everything back together again, right? That kind of thing. But I mean, barring something like that, probably we're really talking about, let's see what we learn through looking at the same things through the enforcement process, and frankly, only in the most extraordinary circumstance, which would probably affect multiple entities, not like single entities, we would entertain a waiver. If it's a single entity, we can do it through the enforcement process. That wouldn't change the workload either way.
Okay, let's open this up for public comment, both on public testimony and on the waiver process. Please.
Thank you. We invite individuals to come to the podium, and for those attending remotely to raise their virtual hand. Please keep your comments to 2 minutes or less, and we'll start with the individual at the podium.
Beth Capel for Health Access California. We concur with the staff discussion about limiting waivers and the fact that the law regards them as an on-off switch, to borrow Dr. Pan's description, that once enforcement has been waived, it's been waived in its totality. In our understanding as among those who were in the conversations developing the law, the waiver was aimed at things like a once-in-a-century pandemic. If you'd been sitting here in March of 2020 or April, you might have chosen to waive enforcement because of the uncertainties that happened. But that was talk about an act of God, that was a once-in-a-century pandemic. Another circumstance we can think of is a situation in which a hospital is reopened, as we hope happens, as Madeira is currently contemplating. With respect to an earthquake, I would have a different perspective as somebody who was dealing with hospital workers during Loma Prieta in 1989 and Northridge in 1994, which is the degree of effect varied widely by the nature of the hospital. Northridge was the worst in Santa Monica. There was one hospital that never reopened, and any care that was provided in the parking lot. That is exactly what the seismic retrofit laws are designed to prevent in the future. So I would think we would want to, in that circumstance, go through an enforcement process where we consider the degree of impact rather than just say every hospital that's affected is exempt. I would also remind us we're only talking about circumstances in which an entity exceeds the target. If a hospital closes, they're not going to exceed the target. So, and that's not apocryphal. In Loma Prieta, there were several hospitals, if I remember correctly, that were yellow tagged and never reopened after the quake.
2 minutes.
So that is the degree of impact, as I say, varied. Thank you.
All right, turning to a member of the public online, Jamie Luck, we have unmuted on our end. Please unmute on yours.
Oh, yes, hello. I'm a therapist with the NUHW union at Kaiser Permanente, and I just wanted to make a statement about looking at Kaiser's financial reserves and the restrictions in providing healthcare at the same time. We wanted to advise and invest in putting more resources into behavioral health care. As a psychotherapist, we're seeing a reduction or pressures on the workforce and a reduction from 2023 and a failure to follow through on the corrective actions of the DMHC. We want Kaiser to behave like a medical provider and not a monopolist. And we're hoping that the insurance board could help advise the DMHC and help to enforce the penalties and corrective actions in order to improve the behavioral health care, which again, they seem to be restricting as increasing profits and increasing the premiums next year on patients. I just wanted to make that public comment. Thank you.
Thank you. Turning to the individual at the podium, please go ahead.
Thank you. Good afternoon, Jenny Nguyen with the California Hospital Association. We appreciate today's focus enforcement discussion on technical assistance, public testimony, and waiver of enforcement. And my comments today will be on those three components. The legislature clearly directed OCA to meaningfully implement each 4 steps in the progressive enforcement process. And we are pleased to see today's focus on clarifying the actions OCA will take to provide technical assistance. However, additional components of the process could be further clarified. For example, we believe that entities should have the opportunity and time to make financial and operational changes based on the technical assistance provided by OCA and to improve their spending performance to meet the target prior to going through subsequent steps of the progressive enforcement process that will be more burdensome for both regulated entities and the office itself. As for public testimony being optional as presented by OCA, we believe that the progressive enforcement steps laid out in statute are all necessary, with each step giving entities the chance to engage with OCA and to work collaboratively toward our shared goals. Lastly, on the waiver process, while we disagree that the waiver is an optional process laid out in statute, we ask for a clearly defined process for entities to explain why they were unable to meet the target and for the office to cease with progressive enforcement actions as warranted. Moreover, OCA must ensure that this is a transparent process defined through regulations so that all entities have a clear understanding of how they will be assessed and enforced against the target. Thank you.
Thank you. There are no more raised hands online and no one stepping to the podium. That completes public comment.
Okay. It is 12:24, 1 o'clock? 1 o'clock. Let's come back at 1 o'clock we're going to take a lunch break now. It's 12:25. We'll reconvene at 1 p.m. Thank you. Okay, I'd like to reconvene the meeting. If we could take roll, please.
Yes, taking roll call. Sandra Hernandez.
Here.
Richard Cronick.
Here.
Ian Lewis.
Present.
Elizabeth Mitchell.
Here.
Richard Pan.
Present.
Don Molds.
Here.
Secretary Kim Johnson.
I am present via online.
Thank you.
Great.
That concludes roll call.
Great, we have a quorum. Noting that Secretary Johnson has informed staff in a timely manner that she would attend remotely today due to illness that she reported. Pursuant to SB 544, Secretary Johnson did relay her sickness and seeks to participate in the HCI meeting today via Teams. Staff has confirmed that all the requirements under SB 544 have been met. Secretary Johnson is also aware of the requirements placed on her by SB 544, and she will follow them. Secretary Johnson, do you have anything to add to this?
Thank you for the board's consideration.
If there are no objections to Secretary Johnson appearing remotely, I propose a motion that she be allowed to participate.
So moved.
Second.
Any other conversations? If not, do we need public comment on this? I don't know. Sure. Sure. Anybody like to take public comment on this?
We'll now take public comment at the podium or online regarding the inclusion of Secretary Johnson.
Great.
Seeing no raised hands, that completes it. Thank you.
Thank you. Can we take a vote for that, please?
Yes, Sandra Hernandez.
Aye.
Richard Cronick.
Aye.
Ian Lewis.
Aye.
Elizabeth Mitchell.
Aye.
Richard Pan.
Aye.
And Secretary Kim Johnson.
Welcome, Dr. Johnson. Secretary Johnson, I don't think you need to vote on this. We have a motion to approve, and I'll hand the meeting over to you.
Thank you very much, and appreciate you filling in Vice Chair Hernandez. And I think we are here on item 4, and I'm going to turn it over to Vishal just to transition us and make sure we're clear on our next steps here.
CJ Howard will present this item.
Good afternoon. Thank you. My name is CJ Howard, the Assistant Deputy Director over the Healthcare Spending Targets Branch within the Office of Healthcare Affordability. We will go on to the next slide. So we're going to be discussing the data submission penalty and penalty amounts. We wanted to continue and follow up on questions from the board members about the proposed $5 per member penalty for failure to submit data in the context of the data submitters and what penalties look like for other state agencies. The average $5 per member penalty for health plans would be $2.7 million, ranging from $18,575 for the smallest of registered plans to north of $41 million for the largest registered entities. More context, just in terms of how these fines kind of compare to other penalties that have been levied by Health and Human Services Agency departments. The largest fines administered by the Department of Managed Healthcare include the following two. One was to the Kaiser Foundation Health Plan for $50 million and $150 million investment over 5 years. The matter involved the plan's delivery of behavioral health care to enrollees, including timely access to care. The local initiative Health Authority for LA County, or LA Care Health Plan, was levied a fine of $13.5 million and a $21.5 million investment. The matter involved processing requests to authorize care, handling of member grievances and appeals, and oversight of contracted entities to ensure delivery of quality and timely care. Go to the next slide, providing some additional context of notable fines from DMHC. We see fines ranging from hundreds of thousands to several $1 million for violations related to timely implementation of independent medical review determinations, violations related to processing of claims, payment disputes in a timely manner, and among others, violations related to the processes of health plan member complaints in a timely manner. Next slide. So previously, we answered a board member question about the proposed penalty for the failure to submit data as a percentage of the plan's total annual revenue. That amount varies by plans, ranging from 1/100% to 0.14%. On average, the $5 per member penalty equated to 0.07% of a plan's total annual revenues, reminding that a lot of the total annual revenues are for direct patient care and the total medical expense. We also wanted to contextualize the proposed penalty amount as a percentage of a plan's annual net profit. While the amount varies by plan, ranging from -3% when plan posts losses to greater than 3.8% when there are profits, positive profits. On average, the $5 per member penalty equates to approximately 1.46% of a plan's annual net profit. There are various measures for profit. The above information was calculated using DMHC's net profit and loss. And just for further context, from 2022 to 2024, the range of plans with annual negative profits was between 4 and 9 plans on any given year. Additionally, we wanted to look at the proposed penalty as a percentage of the plan's annual excess tangible net equity. This metric is important because ET&E is the amount beyond the amount of tangible net equity that plans are required to maintain by the Department of Managed Healthcare. While the amount varies by plan, ranging from -0.5% to just over 9%, on average, $5 per member penalty equates to approximately 1.1% of a plan's excess tangible net equity. Go to the next slide. I'll share some feedback from the advisory committee. Members expressed concern that the proposed penalty structure will not motivate healthcare entities to timely submit data, and larger entities would potentially view the penalties as inconsequential and simply the cost of doing business. A member suggested that instead of the two $10,000 penalties for the untimely submission of data, increasing the penalty amount to $10,000, $50,000, $100,000, or $250,000 based on a small, medium, or large plan or large entity size. This could encourage entities to submit their data closer to the deadline. A member appreciated that the fines multiplying each year makes it expensive for submitters that they have to comply. This reduces the incentive for submitters to skip a certain bad year because the fines would continue to multiply. A member commented that having public testimony to explain the reasons for non-compliance is valuable. And at this point, I'd like to ask Board Member Pan, who attended the AC meeting, if there was anything else that he'd like to share that he heard from the AC's discussion that is not highlighted here.
No, I think this is an excellent summary of the discussion. I think the underlying theme is that while certainly we believe most plans will comply because it's the law and that they, and they want to act honorably, that what we unfortunately what we have to do is these rules are for the bad, for bad players, ones who for whatever reason decide not to, and we need to have a sufficient fine to deter them from that bad behavior. So, we expect should not be hopefully this is a penalty that no plan would ever actually even contemplate wanting to have, and would not actually just don't want to be penalized, period. But unfortunately, if you do have a plan that or for some reason does not want to comply, it needs to be sizable enough to not make it a cost of business.
We can go to the next slide. One more. So now we'll go over some updates to the proposed penalty structure. I'll begin with the considerations for the proposed penalty structure. The penalty needs to be reasonable, provide an incentive to submit data timely, and deter entities from not submitting or withholding data or to evade spending target enforcement. If an entity fails to submit data, OCA is unable to measure total healthcare expenditures or enforce the target for payers in fully integrated delivery systems. If an entity fails to submit the data, it may also impact reporting of spending for other healthcare entities, such as provider organizations that are measured based on attribution of total medical expense. If entities do not submit data, the office could take administrative action and request an administrative law judge to compel entities to comply with data submission requirements or pursue other legal actions. It could also notify licensing agencies of the entity's failure to comply with California law. Next slide. So we've again provided the statute here. The high-level things for the director to consider include the nature, number, and gravity of offenses, the fiscal condition of the healthcare entity, the market impact of the entity, and that administrative penalties shall not constitute expenditures for the purposes of meeting cost targets. We can go to the next slide. Go back one slide. Do you want to?
Yeah, just want to make sure that the board's tracking the text at the bottom, that to align with these requirements, the penalty amounts approved by the board will denote up to. It's a maximum penalty, but then when the director actually imposes the penalty, they need to take into account these considerations.
Thanks. All right, now we can go to the next slide. So we'll return to the proposed process and penalty scope and range, and I'll note where updates have been made based off of input from advisory committee and board. So again, data is due to the office on September 1st, and we have 2 optional extensions that allow data submitters more time to submit. Both have some requirements about keeping OCA updated with regular status updates. These 2 are unchanged, and the second one would be, again, for 15 days or another date agreed upon by the office, so that we can support and work with the entity to come into compliance with submitting their data timely. Go to the next slide. Next, if the data has not been submitted by the submission deadline or by the end of one or both extension periods, submitters would be subject to an initial flat untimely data submission penalty of $10,000. If the data are then not submitted by November 1, the submitter would be subject to an additional flat untimely data submission penalty of $50,000. This is an increase from the prior version of the proposal, which had the second penalty at an additional $10,000. Also on November 1, progressive enforcement would begin. With a notice that the submitter has failed to submit data, the office would still require the plan to submit data. We would provide technical assistance and allow up to 30 days for the submitter to submit data. This moves the progressive enforcement process up from December, from the prior version of the proposal. And the office still has the optional step of a public meeting with the meeting and public testimony for submitters that have not submitted by November 1st. Next slide. If data is not submitted by December 1st or the agreed upon date, the entity would be subject to a per member failure to submit penalty in addition to the untimely data submission penalty. This moves the per member penalty up from January 1 in the prior version of the proposal. For data submitters that repeatedly fail to submit data, each year the failure to submit data penalty would double, so $5 per member in year 1, $10 per member in year 2, $20 per member in year 3, and so on. OCA will make all public penalties public once formally assessed, and OCA could continue to pursue other legal remedies in addition to penalties to acquire the submitter's data. The office could take administrative action and could notify the licensing or regulatory agency of the entity's failure to comply with California law. Next slide. This slide shows the example timeline for data submission penalties for submitters that we have that have requested both extensions. We've shown this example during previous board meetings, but notice here we have updated when the progressive enforcement actions begin, now on November 1, and we have updated when the failure to submit penalty begins, now on December 1st. Next slide. This slide shows an example of the data submitter penalties for a submitter without the optional extensions. Here we see that the first penalty begins on September 1 and the rest of the timeline remains unchanged. Next slide. This slide shows examples of penalty amounts for various sizes of data submitters. We have updated this slide to reflect the larger additional untimely data submission penalty, and the proposal is for a $5 per member penalty in the first year and doubling to $10 per member in the second year. We can see examples of those amounts in the last two columns on the right. Next slide. I want to note the green arrow here, which indicates a current or future item for the board. Prior to turning to a draft motion for the board's consideration, I'd now like to turn it over to the chair to facilitate discussion of the office's current proposal to establish two flat untimely data submission penalties, the first one being $10,000 and the second one being $50,000, establish a $5 per member penalty for failure to submit data, and double the per member failure to submit data penalty in each subsequent non-compliant year.
Thank you, CJ. And just to clarify, this was item 5A. That's my oversight there. So just appreciate the continued work and discussion on this data submission enforcement, and noting that this $5 per member penalty is significant. And appreciate you also laying out the other types of remedies that the office will consider if it has problems getting that timely data. So I also appreciate that we would be transparent in the spirit of transparency, looking to kind of name the missing entities as a way to motivate them in making their data submission a priority. So again, appreciate that we have a number of remedies at our disposal, inclusive of the fiscal as well as the legal as well. So I will turn it over to the board for any questions.
Secretary, I don't know if you can see well enough. Would you like
I think that is
Board
Mr.
Member
Pan.
Hernandez to help us?
Oh,
Yeah,
please, that'd be great. That'd be great.
Thank you. So just to clarify, and I know we talked about this before, the double per member for submitting the data penalty each subsequent non-compliant year is that, so you have the non-compliant year, they haven't submitted, so I just want to clarify, they haven't submitted their data yet. It's now the next year. Is it the double on the next year's submission being late? Is the double also on the still not submitted one for the prior year? So I'm just trying to clarify. Or is there any time thing? I realize that basically once it's past a certain point of time, that data is not as useful. Although I don't know what historically, if we were trying to do trends, we eventually would want data, even if it's kind of, past the recent date. So obviously it would still be an imposition on our ability to do many of the things you talked about, in real time or in contemporary time. But would we also still want that old data in the past to be served? So if we need a historical track to do comparisons and so forth. So anyway, can you please clarify that?
Sure, I'm gonna try my best and see if we get there. So a couple things. So one, yes, we still want the data, even if it's after the December 1 deadline and we've assessed the penalty, we would still be pursuing other actions to still try to acquire and remember, every time that we collect data, we're collecting 2 years worth of data. So we would still, try to get those 2 years of data through other means and mechanisms, but there would still be a penalty associated with the at that point, very late and untimely submission and failure to submit the data. So there would be the per member penalty. Let's assume, we'll just for sake of illustration, that we for some reason are unable to acquire both years of data. It's 2027. We're trying to collect the 2026 and 2025 spend. This following year, it's now 2028. We would still need, we're going to get 2 years worth of spend data, so we still would have the trend. There's a year that would drop out where we're not collecting the same year twice, but we would still then expect to have that data, so we would still be able to piece together the historical picture. In order for an entity to, let's say that they're like, well, again, thinking of this cost of business argument, I just don't ever want to submit 2026 because that's the year that things went awry, then they would need to not submit data 2 consecutive years in a row, right? Because we're talking about complete and accurate data submission, and each year a complete and accurate data submission would involve submitting to us both years.
So
Does that help?
yes, so basically this $5 per member, which will become $10 per member, is a one-time for that submission. I realize you're doing 2 years.
Right.
So there's no additional penalty for not turning it in subsequent year. Well, let's put it this way. You're doing 2 years. I guess if you're 3 years out, maybe you don't care about the data anymore. Anyway, so I don't know if there's any like you're just not turning it in, right? So for some reason you don't turn it this year, you don't turn it next year. We still don't have 2006 or whatever, or whatever number, whichever year. In the third year, do we care or not? Is there some other penalty, or well, we already hit you with the penalty back then, and so I guess we write that off? Or I'm just trying to clarify what the plan is if someone just doesn't turn in that year. So by the time you're now 3 years out, that year no longer is in the 2 years.
That's right.
Any consequences any additional consequences? Consequences were already hit already. Or do we care?
At that point, we'd be relying on the other legal remedies.
Okay. All right. So there would be no other fines or something. It would be the other. And then I guess the other question is in terms of the administrative actions. Do you know what the average time is to actually execute an administrative action? I realize that's perhaps case specific, but in general, are these multi-year efforts, or is it how quickly does an administrative action actually result in some decision?
I think we'd have to get back to you on that.
Okay. Oh, all right. There you go.
Unfortunately, there's no average time. It's, we file an administrative accusation, and then a hearing is set, and that's just on the calendar of the OAH. And then, depending on how long the administrative law judge takes to render their decision, there's no average time.
Okay. Is I guess sensitivity analysis, other similar types of decisions? Do we have? I mean, are we talking years? Are we talking it's in the scope? Again, I realize somewhat speculative, but typically, is this something that takes 5 years or somewhere between 3 and 7 years, or
unlikely to take years?
Okay, all right. That's why I'm just clarifying. Okay, thank you.
Thank you, Dr. Pond. Yes, I think that's Ian. Is that right?
Thanks, Secretary. Yeah, I'll just come out and say this formula, these numbers seem way too low to me. I think the consistent feedback that you've got is that, I mean, yes, we need to make sure it comes in timely, on the calendar so that we can do what we need to do administratively. But the other thing we're trying to do is disincent total non-compliance. And if $5 per member per month averages 7/100ths of a plan's 7/100ths of a percent of a plan's revenue, it's going to take over 4 years, 5 years for this doubling to get to a point where you're even talking about 1% of a plan's revenue. And so the incentive there to, if they're exceeding by 2, 3, 4% the target, the incentive to absorb this as a cost of doing business it seems to me huge. And the examples you gave, much lower examples with Kaiser and the other one, those underscore that for me, right? Like that $50 million fine at Kaiser was the tail end of years worth of penalties, and by all appearances, it still hasn't fixed the problem there. And DMHC has access to the administrative law courts and so forth. I don't pretend to know how often they avail themselves of that, but that doesn't seem like a recipe for successful enforcement. And the last thing I say is the steeper the steeper these penalties escalate, the less likely we are to be in a position where we're even having to think about imposing them. If it is a truly deterrent penalty structure, it'll be a non-issue. The plans will comply.
Thank you, Ian. I wanted to reframe kind of the denominator that we're working from. So we did present numbers as a percent of revenue, but we have to keep in mind that revenue doesn't mean all the dollars that a health plan retains. They pay out much of that in claims. So that's why we included additional metrics where we're considering profits and tangible net equity, because we think those are more appropriate than looking at it as a percent of revenue.
We had discussed, I think the last time we discussed this, whether kind of waiting a year to escalate the penalty fit with the value of the data. I think I and a few others were concerned that, well, you don't get it on December 1st. If, is it still worth something to you on February 1st or March 1st? And I would have thought the answer is yes. I mean, might not make the kind of first report, but you can do a revision to the report. And this structure kind of says to a plan, okay, we missed December 1st, getting it on February 1st versus the following, November 30th is no different. And I'm wondering why you decided to kind of wait a year rather than having any sort of further penalty sooner than that.
Well, the penalty would double in the second year.
Right, it'll double in the second year, but that means if you're in IT and you haven't been able to get these data to in a way that works, and I should say, I mean, I'm quite heartened by the earlier slide you presented that 48 of the 50 plans have submitted data that works already, even without any penalty structure in place. So this is, very good news, I think. But if you're in IT and you're trying to, get resources from the plan to fix whatever problem it is that has kept you from, getting the data, the plan manager may well say, hey, why bother now? We'll wait till next year, or at least 11 months from now, as opposed to trying to get it done in 2 or 3 months and getting the resources earlier on.
Yeah, I think to answer your question, I think like there would still be action being taken after December if they didn't comply. They would be hit with those penalties, and then if they're not responsive to that, then we would need to pursue other legal remedies.
And I guess to the extent we're trying to use these penalties as incentives, it would make more sense to me to increase the penalty 3 months in or 4 months in, rather than waiting a full year for the increase. But that only makes sense if you're going to be able to do something with the data if you got it 3 or 4 months in, which I would think you would be able to make use of it.
Yeah, if it gets to us in a time frame where we could include it in the report, we will. It just kind of compresses the time for validation and engaging the submitter to make sure they submitted it correctly.
Thank you. I wanted to align myself with Board Member Lewis's comments, and from two recent experiences, one with the transparency reporting requirements from the feds for hospitals. We're 5 years in and we're still way below actual compliance nationally, and that is with an increased penalty. The increased penalty helped, but it still, I think, is somewhat inadequate. So I'd go big or go home here. Additionally, we are working with some health plans on TIC report or the transparency reporting. And to your point about being able to get internal resources, they couldn't get the internal resources for reporting until this became problematic enough that their C-suite noticed. So perhaps a larger penalty will make that happen sooner too. So, and you know, if they submit on time, they don't have to worry about it.
I would just add, I think everybody's going to know what the timeline is to submit. Those entities should be working to be able to submit the data on a timely basis. I sort of agree with Rick that waiting a year or another 2 years or another 3 years is a diminishing value to us on data. And so I don't know why we wouldn't accelerate these in a way that is meaningful for getting data in a more timely way, whether that's 3 months or 4 months. It's not the point.
I wonder if one possibility might be, and I'm skipping ahead to your draft motion slide, instead of doubling the amount every year, doubling the amount every 3 months. It wouldn't completely solve in your concern that $5 isn't enough, but it'd be $20 a year later, which is quite a bit more as a percent of profit.
I believe that's
Yeah, actually, yeah, and just to confirm, I think I recall our previous discussion in terms of the utility of the data. And you mentioned that, of course, it's not only about the data on that plan, but that plan data is important for us to get the whole collective picture, as well as actually important for us to that then cross links with our private provider assignments and stuff like that. So I mean, there's significant consequences for us to not getting to having a plan not submit their data. I mean, it's not just simply, oh, well, we can't do something with that plan or whatever else. It actually has rolling effects. If I recall, you did say that in some ways we really do need that data in order for you to do the report. I thought you said it was at the end of the year. So I appreciate Dr. Koenig saying, well, 3 months is better than that, but if I recall correctly, you said, I mean, we are asking for September and we're giving people extensions, but kind of the last moment realistically really is, realistically is the end of the year. We need to have it, right, in order for us to be able to use it in a way that not only is for that plan, but also for all the other parts that we need that data for, correct?
Yeah, correct.
Okay. So to me, our penalty structure should reflect that, right? And I think our justification for whatever fine we give, I think someone made reference to that, should reflect the fact that this not only is, of course, a non-submission, there's not only an impact on, about that plan, it actually hampers the work of this board and this office and the agency. And therefore, it should be reflective of that consequence.
The only thing I'd flag, you're correct that the data is important because we're going to measure physician organizations with it as well. I think the concern of it doubling every 3 months is that kind of, at some point the threat of penalties, is one thing, but then there's also legal remedies that we pursue, and then kind of how the doubling kind of has to end at some point, or it could be in perpetuity, I suppose. But then at some point we kind of have to be, we weren't successful through the penalty structure, and then we need to move on to the legal remedies. So I want the board to keep that in mind as well.
I appreciate that. That's part of the reason I was asking the question. I realize that's somewhat speculative, exactly what the general length of time we would anticipate for those other things, how far out that would be. I realize you can't put a pin on exactly how long, but at least some sense of scale. So I guess the question is that whether we should just have a larger penalty up front, larger than $5 for just not getting it submitted by the end of the year, right? I mean, is that the right number, right? So I appreciate, and I did propose the doubling in past meetings because it's a way to kind of push things along. But are we starting at the right place? If that's because ultimately that's when we really need the data. I mean, this penalty only kicks in when it's like, hey, you're missing our last moment that it's useful to us for this year. Obviously, it still has some historical value, but maybe we should just start with a larger number to start with, to be sure, because otherwise, again, it hampers our ability to do more than just that plan, and that's the concern.
Hi, I'm Heather Klein-Hoganson. I am the Assistant Chief Counsel of Compliance. And I just wanted to clarify. So if we were to be in the situation where it's past December 1st, we're going to impose this higher penalty, we would be proceeding with an administrative action, and we would have an administrative law judge say, yes, this amount is due. So A, you must pay the fine in a certain number of days. B, you must provide the data. And then if they didn't pay or they didn't provide the data after that, then they are in violation of administrative law judge's order. That could also go to their licensing entity's attention and perhaps affect their license status, or it could result in an action to enforce a penalty in the Superior Court. And at that point, a judge could order interest, et cetera, et cetera. So, but in order to have that administrative action, we have to have a penalty and then go forward. We can't, if we just keep saying we're adding more money, then we'll never get to the action.
Okay. So then that makes more sense than to say we should have a larger penalty up front, and if you don't meet the deadline, here's the penalty, and then here's the fine, and then the administrative action, right? Like you just described. So.
Well, I mean, a $5 per member fee would be a pretty large amount.
Okay, well.
But if you wanted to say, if it's past this date, there could be another option of adding additional penalties after we've gone through administrative action.
Okay, so to clarify, just want to be sure I understand what you're saying, because there's this conversation about, well, we do sequential fines, we'll never get to administrative action. So you're saying that, I mean, I assume at the December, right, when we actually need the data, the last minute of needing the data, I should say. Ideally, we get it earlier because we don't want to try to do everything in the last minute. We can do a fine and administrative action, and we can charge a subsequent fine? Or you're saying that, because I thought I was hearing, no, we just need to end the fines and move to administrative action. Can you do an administrative action and then a subsequent fine, or does that preclude us from doing administrative action prior to a subsequent fine?
If they're in violation of providing the data by December 1st, right, that would be a fine that we could have an administrative action for. We could have an additional violation for continued refusal to obey, so that would be a different action.
Okay. I'm just trying to figure out what's the most effective way to ensure. I mean, ideally, no one would ever get penalized. We get all the data on time. That's what I want in the end. But we need to be sure that someone who might not be so motivated sees the consequences and would still decide that the consequences are worse than providing the data. That's what we want to try to get to. So I'm trying to figure out, well, I think we're all trying to collectively figure out how to make that happen, because ultimately I prefer we never get a fine and we get all the data. That's the best of all worlds. So, but if the fine's too low, the concern is that someone might actually say, I can afford to pay the fine, and then I'll just drag this thing out, which hurts us, or the people of California, right, who we're acting on behalf of. So I realize $5. So I guess the question is $5 per member per month, which is still large compared to previous ones, but I mean, is it sufficient? But as a percentage of not even revenue, but even as the other ones is, one can argue it still seems to be a manageable percentage. It's like what?
If I could just, in hearing this conversation about the administrative law judge and what actions they might take, it seems to me that, and given that we would all like to see the data sooner rather than later, and ideally around the original deadline, it seems like having a larger penalty up front that is consequential, and that then going to an administrative law judge to enforce would be more aligned with what we're trying to do ultimately in terms of disincentivizing untimely submission of data.
Thank you for that discussion, board. Any other comments from the board? I completely appreciate the discussion, and again, with our goal and objective in mind all along here. So I think I know we have as our next item the actual motion, but I want to just be clear, and maybe as we introduce that one after public comment on this one, we can just be clear about any additional guidance. I think we're trying to take our best efforts to understand how these remedies, if you will, or penalties are going to interact with each other, and what will be the impetus to get someone to act and share the data. So appreciate that. We're doing our very best to try to understand that with all of the remedies that we have at our disposal. I'm going to go ahead and open it up for public comment at this time.
Thank you. If you are a member of the public attending virtually, please use your raised hand feature to let us know you'd like to speak, but we will start with individuals in the room. First person at the podium. Thank you.
Beth Capel for Health Access. We thank the board for the discussion. We are pleased that to date most entities have reported timely and completely, but past performance is no guarantee of future performance, especially when we are looking at potential commensurate penalties that are hundreds of millions of dollars. At that point, a small penalty, and we regard the $5 penalty as a small penalty, is no guarantee of future performance. We would ask, given the board discussion, that the board not vote today and consider and ask staff to come back with a revised proposal that's more in line with the provisions of the law governing OCA than the law governing other agencies. We are opposed to the current proposal as not sufficient to induce compliance, especially when we are to the point where we have enforceable targets. We did make specific recommendations in our letter this month, and we realize that essentially crosses in the ether when the staff is finalizing the proposal that's before you. We also want to put the penalty in the context of national revenues, because that's the scale of the organizations that you're dealing with, and that's what the law points to. These health plans that you're dealing with, the top 5, have national revenues ranging from $100 billion to $300 billion with a B. Penalties that are in the low millions are not to scale and will not be sufficient to assure compliance. We also base this on, and those of us who participated in developing the law based the law in part on our experience with other agencies and the experience they had. So the Knox-Keene Act was enacted in 1975 when HMOs were small, nonprofit, California domiciled entities. That's not what they are today. And we have had experience with DMHC where we had large health plans routinely ignore California law. That was the case with rate review. It was also the case where we've had several large health plans that ignored the law on paying for emergency care out of network, even though California law has been what it is for more than 30 years. In our letter, we provided data on national revenue. We also provided data on what it would look like if these plans missed the penalty by 1%, going from 3.5 to 4.5%. In that case, the penalty would range from several $100 million to $700 million. So we just don't think this is enough to induce. We're happy people are complying now, but that's no guarantee that when they're facing commensurate penalties, they will continue to do so. Thank you.
Thank you. Turning to online member, C.R. Keegan, please go ahead and unmute on your end.
Hello, this is Kara Keegan with the National Union of Healthcare Workers. NUHW represents thousands of behavioral health providers across California working in both community-based and institutional settings directly for health plans and through contracted providers. We want to express our appreciation for the efforts of OCA staff and board members to ensure that OCA's mandate is successfully implemented. And as OCA considers enforcement procedures for both data submission and spending target compliance, NUHW would like to urge the adoption of strong, transparent enforcement mechanisms that include public accountability, escalating penalties, and limited use of waivers. Earlier today, we reviewed the DMHC's history of enforcement actions, including its settlement agreement with Kaiser Permanente for behavioral health violations. We encourage OCA to learn from DMHC's enforcement history as it develops its own framework. Despite DMHC's record $50 million fine and 2-year corrective action plan, against Kaiser. Kaiser's behavioral health system, unfortunately, has not improved for many patients. In August 2025, we surveyed our members, and in the survey of behavioral health clinicians that work at Kaiser in Northern California, 56% of respondents reported that since the DMHC settlement was signed in October 2023, Kaiser's mental health care has either stayed the same or worsened for patients. So while the $50 million settlement may sound significant, it's a minor expense for a corporation that reported $12.9 billion in profit last year and holds $66 billion in reserves. We want to state our support that we support an enforcement framework that is standardized with very limited allowance for enforcement waivers, ensuring consistent application across all entities, transparent with public access and input to hold entities accountable, and proportionate and escalating with financial penalties scaled to the size of the entity, ensuring that compliance is a legal obligation and not just a cost of doing business. We would like to express our concern that the current proposed penalty structure will not motivate healthcare entities to timely submit their data. And we believe that learning from past regulatory shortcomings and centering transparency and accountability, OCA can ensure that its enforcement powers truly protect patients and allow the office to uphold its mandate. Thank you.
Thank you. Acknowledging the person at the podium, please go ahead.
Hi, good afternoon. Anate Millers on behalf of the California Association of Health Plans. I just want to take a moment to acknowledge OCA's ongoing work to implement the data submission program and share that health plans have been compliant with the office's data submission requirements since the start. even before any penalties were in place. We've taken these requirements seriously and have been submitting data accurately and on time. Our industry has approached this process in good faith and as a true partner to the state. Plans have been working closely with OCA staff and their consultants to navigate evolving data specifications, new files, and technical challenges. The first year of submissions naturally came with some learning curves, but we adapted quickly and cooperatively to meet those expectations. Given that compliance has been consistent across the board, we appreciate that the office recognizes these efforts as it finalizes its enforcement framework. We look forward to continuing to work collaboratively with OCA to refine the data process, improve consistency, and ensure that the information collected continues to be meaningful and useful to the state's goals. Thank you.
Thank you. Seeing no more requests, that completes public comment.
Thank you. Board, given the discussion on this item, and given, again, I think the clarity that the board members sought in terms of the interactions of the remedies and the timing frame by which data could still be useful, I'd like to consider us actually tabling item 4 and bringing that back to our November meeting for some additional discussion. And would also like to ask both CJ and Vishal and team if there are other questions or points of clarity that you need from the board to be able to develop another recommendation.
I think we got some, at least what I heard was kind of with the per member penalty having some type of increase to that, or was it kind of just the amount of the $5 per member penalty?
I mean, my suggestion was an increase, but I think you heard from others, and I think I would agree with them that probably larger initial penalty makes more sense if the data are not much useful to you 3 months or 6 months later. That the real, if the main use is going to be for December, then the larger penalty in December probably makes sense, is what I think you heard from Dr. Pan and others.
Thank you. First of all, I do want to acknowledge from the health plans that, yes, I appreciate that they have to date been compliant. I want to recognize that. And hopefully, again, I said our goal is never to fine anyone because everyone gets their data on time. That's the best outcome. I would say that, for example, as you presented the penalty amounts here, and I think we are talking about probably a larger penalty for passing the December, which is kind of really the last minute, as you've told us. You may note in your analysis, for example, that the $5 penalty would basically equate to approximately 1.46% of the plan's annual net profit. So we're not talking revenue, not the net profit, right? With a range from -3% to 3.84%. That seems to me to be still a bit low. I mean, if someone says, oh, okay, well, it's going to cost me 1.46% of my profit or 2% or something. So I'm not sure how much of a deterrence that is if you decide it's a cost of business. I think we heard some testimony about the fact that the entities are even larger if you don't count outside. I assume this is the California side of things. But maybe when we think about scale, maybe something a little larger in terms of percentage makes more sense.
Yeah. I wanted to clarify that the 1.46% that you cited, it's not saying it's 1.5% of a plan's profit. It gives a range, right? -3.
Yeah, well, the range is -3 to 3.84.
On average, it's 1.5.
Right. So let's say even at the top end of the range, it was a 3.84% of their net profit. So I still get to keep the remaining 96%, 96 point something percent, right? I mean, it's so. Depending on, obviously, again, hopefully the motivate, again, I think most of the plans will do the right thing. They know what the law is, et cetera. This is really about the bad actors. And in the end, hopefully we never have to collect because no one actually triggers this.
If I can request, I think there maybe look again at the statistics. I mean, plan revenue is probably somewhere in the kind of $700 a month or $900 a month range. You know, if profit is 5% of revenue, that'd be $45 a month. So it doesn't sound right to me that $5 a month is 1.46%. It seems like it should be closer to 10%, or I'm not sure exactly, but I'd request a review of those statistics. They don't quite seem right.
Yeah, we'll double check the numbers.
If I could just add on that, you know, there was a comment in public comment, look, considering the fact that these are national entities in many cases, I'm curious, do we have the ability to look at some kind of revenue-based, or at least know what the proportionate penalties are on a revenue basis nationally, not just on the state health plan? I don't know if our statute allows us to extend that far. I also just, it was helpful, and though I'm still a little unclear about what it would mean, you know, filing an administrative law action on a December penalty, and then maybe it's a separate one if we were to have another penalty in January. You may come back to us and say data's useless to us in January, and so it has to be December, and that would clear that up. I would like to understand a little bit more about what, say, DMHC's experience has been with administrative actions, maybe in the cases you listed or others, just to understand what it means to practically enforce this law through a law judge.
The other thing I want to acknowledge, and we did say it was emphasized, up to. This would be the maximum penalty. So, you know, the staff does have some discretion if there were reasonable whatever to negotiate. So we're talking about the upper end. And I think the upper end may be a little too low to give to, so that if we really needed to. So again, appreciate the fact the plans are doing it now. Appreciate that hopefully we'll never have to trigger this, but this is kind of like, this is the fence, right? So good fences make good neighbors. This is the fence. Exactly how strong is the fence? Be sure people are going to be doing the things they're supposed to do. Hopefully not because of the penalty, because it's the right thing, but unfortunately for some people, it will have to be because of the penalty.
Hey, Don, does CalPERS have any experience with the Administrative Law Office as it relates to these kinds of matters?
As it relates to these kinds of matters, no, and we use them in grievances. So our grievance, we have an independent grievance procedure that rolls up to administrative law judges. Other select things, but for the most part, these would be the kinds of things that we put in contract and enforce through contract.
Okay, so without any additional discussion, we'll go ahead and utilize the information taken in today's board meeting to craft a new motion for consideration in November, all things considered. And I think, again, the more that we can be clear about how the various remedies interact with each other, that may help us in landing the final structure. Thank you very much for the continued work on this. I am going to move us to item 5B then, which is spending target enforcement specific to waiver of enforcement, TA, and public testimony.
Yeah, Secretary,
you covered some of that. Completed the full 5. That was all of the 5.
We covered all of it, yeah.
Perfect.
Yeah.
So I will then move to item 6, to our general public comment without objection. Is that where we are? Confirming?
Yes, thank you.
At this time, we will take general public comment. Please raise your virtual hand if you'd like to speak from a remote location, and please come to the podium if you'd like to speak. And please keep your comments to 2 minutes or less. We'll start with the gentleman at the podium.
Hi, Ben Johnson from the California Hospital Association. As we wrote in our latest letter, just want to highlight a growing concern where a major national health plan is leveraging OCA's spending target against small, rural, and independent hospitals. threatening automatic termination of their contracts if they don't reduce their rate adjustments to spending target levels. While we understand that the targets are meant to be a reference point for payers and providers, these aggressive tactics are endangering care in communities that have really no healthcare alternatives. Most of the affected hospitals that we know about are critical access hospitals. Their operating margins are as low as negative 20%. Their public payer mixes are higher than 90% or more. And while reduced rates wouldn't be a blip for the health insurance companies, they'd be devastating for these effective hospitals who've experienced cost growth of 11% over the last several years. So we ask COCA to push back against these strong-arm tactics, and before it's too late, clarify that actions to sustain access to threatened healthcare services in communities across California will not be penalized retroactively by the office. Thank you.
Thank you. Seeing at this time no virtual raised hands, looking back to the podium. Seeing no one approaching the podium. There are no further requests for public comment. That concludes the public comment period.
Thank you very much. And just as a result of me not being able to join you at the beginning, I just want to thank everyone across California who's committed to an affordability mission. And I hope, Director Landsberg, you had a chance to just lift up again the governor's announcement related to lowering the cost of insulin in California, effective January 1st. Obviously, we have real lives across our state and across the country impacted right now with the federal shutdown and other cost issues as a result of those for those participating in our safety net. So just again, appreciate all that's happening on all fronts with a commitment to making healthcare, the safety net, more affordable for Californians across the state. And with that, if there's nothing more from board members, I will seek to adjourn. Meeting adjourned. Thank you so much.